Welcome to this practice question review for the HESI Fundamentals exam. Every question includes a clear explanation why other options fail and the theory behind it. Today's questions are nursing process and safety cover, applying the nursing process, prioritizing patient care, managing falls and restraints, positioning for safety, medication and fire safety. Our website offers free practice questions and study guides to help you master the HESI Fundamentals exam with confidence. Everything's organized and easy to follow, so you can prepare efficiently. Just check the link in the description below, and remember, study smarter, not harder. All right, let's begin. Question 1. A nurse caring for a post-operative patient on the medical floor records several findings from the morning round. The nurse needs to clearly separate the patient's reported experiences from independently measured data when documenting in the chart for the next shift. Which finding is subjective? Your options are A. Heart rate 92 beats per minute. B. Patient reports throbbing headache since morning. C. Oxygen saturation reading 96%. D. Skin warm and dry to touch. Which one is it? Pause the video if you need more time. The correct answer is B. Patient reports throbbing headache since morning. B is correct because subjective data come directly from the patient's report and cannot be independently verified by another observer. The headache description is something only the patient feels and conveys through words. A is wrong because a heart rate counted at the radial pulse is an objective measurement obtained through the nurse's own observation. Numbers gathered by the nurse without relying on patient report are objective findings. C is wrong because oxygen saturation read on the pulse oximeter is measured by a device and recorded by the nurse. It does not depend on the patient's perception or self-description of breathing. D is wrong because skin temperature and texture assessed through palpation come from the nurse's direct observation. These findings are confirmed by the nurse and do not rely on patient verbal report. Every piece of assessment data falls into one of two buckets, and telling them apart is the first real skill the nursing process demands. Subjective data are what the patient reports from their own experience, like a headache or nausea, reaching the nurse only through words. Objective data are what the nurse or a device can observe or measure directly, like a pulse rate or oxygen saturation. Older language calls these symptom and sign. The patient owns the symptom. The nurse and instruments produce the sign. Many students assume any number must be objective, but a pain score of 8 out of 10 is subjective because the patient generated it from a feeling only they can reach. The reverse also happens. A finding can sound like an impression yet be objective if the nurse observed it directly, like the patient vomiting 200 milliliters of clear fluid. What decides the category is the source, not the presence of a number. Picture a woman on her second day after gallbladder surgery. She says her shoulder aches and she barely slept. Both subjective, while the nurse notes her temperature, a soft abdomen, active bowel sounds, and a clean incision, all objective and confirmed. Verbs like reports, states, and rates flag subjective data, while assessed, measured, and observed flag objective data. Neither one is more trustworthy than the other. Good nursing keeps them straight so it can attend to both what the body is doing and what the person is feeling. Question 2. A nurse on a busy unit notices that a stable patient who was alert 1 hour ago is now confused and slightly short of breath. The nurse must decide what type of assessment best matches the sudden change in condition before contacting the provider. Your options are A. Complete head-to-toe with health history. B. Comprehensive admission assessment from scratch. C. Focused respiratory and neurologic assessment. D. Full psychosocial and developmental review. Take a second. Which answer would you pick? The correct answer is C. Focused respiratory and neurologic assessment. C is correct because a change in condition demands a focused assessment of the systems that explain the cues. New confusion plus dyspnea points to a possible oxygenation or neurologic problem, and that pathway needs immediate evaluation. A is wrong because a complete head to toe takes too long for an acute change. The nurse should focus on the systems most likely to explain the new findings rather than gathering broad data right now. B is wrong because a full admission assessment was already completed earlier and would only repeat baseline questions. The patient needs a quick targeted evaluation aimed at the present cluster of new symptoms. D is wrong because a full psychosocial and developmental review does not address the immediate physiologic concern. While valuable in other contexts, it is the wrong tool when oxygenation and brain perfusion may be compromised. Assessment isn't one fixed routine. A nurse chooses between two main scopes depending on what the moment calls for. A comprehensive assessment is the wide-angle version, covering every body system plus a full health history, used on admission or for a wellness visit to build a baseline. A focused assessment is the zoom lens, concentrating on one system or complaint, and it's the tool for tracking a problem and catching deterioration early. Consider an older man who was alert at shift start but is now confused and short of breath. Instead of repeating his whole admission history, the nurse goes straight to a focused respiratory and neurologic check. Lung sounds, respiratory rate and effort, oxygen saturation, level of consciousness, orientation, pupil response, and skin color. Certain phrases steer you toward one scope or the other. On admission, establish a baseline or annual physical point toward comprehensive, while sudden change, new onset, or reassess after an intervention point toward focused. A comprehensive assessment builds the map, and a focused assessment inspects one region of it when something changes. The key question in any scenario is simple. Does this moment call for breadth or for depth on a single problem? Question 3. A new graduate nurse is preparing to perform an abdominal assessment on a patient who reports mild bloating after lunch. The preceptor reminds the graduate that abdominal exam order matters because manipulating the abdomen first can change the very findings the nurse is trying to detect. Your options are A. Inspect auscultate, percuss, then palpate. B. Palpate, first to localize tenderness early. C. Percuss, then auscultate, then palpate. D. Palpate, percuss, auscultate, inspect last. Before I reveal it, which one do you think is right? The correct answer is A. Inspect, auscultate, percuss, then palpate. A is correct because inspection comes first, then auscultation before any touching. Palpation or percussion can stimulate or alter bowel sounds. So listening before manipulation preserves an accurate baseline of true intestinal activity. B is wrong because beginning with palpation can change bowel sound character and may worsen tenderness. Touching the abdomen before listening can produce hyperactive sounds that mislead the nurse about the patient's actual baseline. C is wrong because percussion before auscultation can also alter bowel sounds. Any mechanical contact with the abdomen, whether tapping or pressing, must follow listening so the recorded sounds reflect the true intestinal state. D is wrong because saving inspection for last loses the broad visual data that should guide the rest of the exam. The nurse needs to see distension or scars before deciding where to listen and palpate. Most physical exams follow one order: inspect, palpate, percuss, auscultate. The abdomen flips that sequence on purpose, and understanding why reveals something important about how the gut behaves under a nurse's hands. On the lungs, heart, or limbs, palpation still comes before auscultation. But the gastrointestinal tract is a hollow, muscular, reactive system, and touching it first changes what you hear afterward. Palpation and percussion can stimulate or quiet peristalsis, so any bowel sounds heard afterward no longer reflect the patient's true resting activity. Since auscultation exists to capture those sounds, listening has to happen before any disturbance. Inspection comes first, scanning contour, symmetry, scars and pulsations without touching anything. Then auscultation, listening in each quadrant for bowel sounds. Percussion follows, tapping to tell gas-filled loops from solid organs, and palpation comes last, saving any painful area for the very end. Any exam question pairing the word abdomen with a question about order is testing this single reordering. Remembering that one swap protects the accuracy of the bowel sound assessment, and it's what separates rote memorization from real understanding. Question 4. A patient on the medical surgical floor suddenly reports tightness in the chest and feels short of breath. The pulse oximeter reads 88% on room A and accessory muscle use is visible. The nurse considers what to do first before calling for help. Your options are: A. Begin a complete head-to-toe assessment. B. Document the findings in detail. C. Wait 15 minutes and recheck. D. Raise head of bed, apply oxygen. What's your answer? Commit to one before I continue. The correct answer is D. Raise head of bed, apply oxygen. D is correct because an unstable patient with low oxygen saturation needs immediate airway and breathing support. Raising the head of bed and applying oxygen treats hypoxia while focused assessment continues, addressing the most pressing physiologic threat. A is wrong because A, full head to toe, takes far too long when oxygen saturation is already in the 80s. Stopping for a comprehensive assessment delays oxygen delivery and worsens tissue hypoxia in critical organs. B is wrong because documenting before intervening leaves the patient hypoxic during the time spent charting. Documentation always follows safe action when ABCs are threatened, never in place of immediate intervention at the bedside. C is wrong because waiting 15 minutes to recheck while the patient struggles to breathe ignores accelerating respiratory failure. Hypoxia at this level can deteriorate quickly into cardiac arrest if not corrected without delay. Nursing students learn to assess before they intervene, but when a patient's airway or breathing is failing, that rule has a hard limit, and the nurse must act immediately. The logic lives in A, B, C, airway, breathing, and circulation, ranked by how fast their failure kills. A blocked airway kills in minutes, and inadequate breathing starves the brain and heart of oxygen almost as fast, so it cannot wait for a full exam. Recognizing the threat means reading these findings together: an oxygen saturation dropping into the 80s, visible use of accessory muscles, nasal flaring, and a patient sitting upright fighting for air. Any one of these means breathing is no longer adequate and the number demands action, not a note for later. The first moves are simple and fast. Raising the head of the bed lets the diaphragm drop and the lungs expand, while applying oxygen raises what's available in the blood. Both happen in seconds before anyone else arrives to help. For a stable patient, gather data first. For a patient whose breathing is failing, treat the threat, then keep assessing. The whole skill is spotting which patient is in the bed. Question 5. A nurse reviewing morning labs for a patient with chronic kidney disease finds a serum potassium of 6.8. The patient is sitting up and reports feeling fine. The nurse must decide what step matters most before completing the rest of the morning routine. Your options are: A. Document the value and continue rounds. B. Hold breakfast tray until potassium drops. C. Notify provider and place on monitor. D. Recheck the lab value in 8 hours. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Notify provider and place on monitor. C is correct because a critical potassium of 6.8 raises serious risk of cardiac dysrhythmia. Notifying the provider and placing the patient on a monitor allows fast treatment and early detection of arrhythmia before collapse. A is wrong because charting alone does not address the immediate cardiac risk linked to severe hyperkalemia. The nurse must take action because critical values demand provider notification, not simple documentation in the record. B is wrong because holding the tray does not influence the existing hyperkalemia or its cardiac danger. Diet adjustments are part of long-term management, not the urgent priority for a value already this far out of range. D is wrong because waiting 8 hours to recheck while doing nothing leaves a dangerous level untreated. Hyperkalemia at 6.8 can produce peaked T waves, conduction blocks, and ventricular fibrillation rather quickly. A critical value, or panic value, is a lab result so extreme it threatens life immediately, no matter how the patient looks. Recognizing one is an analysis skill, the moment a nurse stops just collecting data and starts interpreting urgency. Potassium controls the heart's electrical rhythm, so a level of 6.8 is severe hyperkalemia. It slows repolarization, producing peak T waves, then a widening QRS, then a collapse into ventricular fibrillation and cardiac arrest, often with no warning at all. A patient with this potassium level might feel completely fine. Sitting up and asking about breakfast, that calm means nothing, because the first sign of severe hyperkalemia can simply be a lethal arrhythmia. So the nurse treats the number, not the patient's comfort. The right response has 2 parts done together. Notify the provider since treatment like calcium, insulin with dextrose, or a potassium binder needs orders, and place the patient on a cardiac monitor to catch any rhythm change instantly. Charting the value, holding the breakfast tray, or rechecking labs later all leave the heart unprotected. This logic applies to every critical value, whether it's a glucose in the 40s, an extreme sodium, a dangerously low platelet count, or an INR of 6. Analysis means more than seeing the number. It means understanding the harm it threatens and acting before symptoms ever appear. Question 6. A nurse is reviewing a list of diagnoses on a patient with newly diagnosed pneumonia. The instructor asks the student nurse to identify which one is a true nursing diagnosis rather than a medical diagnosis, since care planning depends on naming the patient response correctly. Your options are A. Impaired gas exchange related to alveolar changes. B. Community-acquired pneumonia, right lower lobe. C. Hypoxemia secondary to bacterial infection. D. Streptococcal pneumonia with consolidation. Which would you go with? Lock it in before the reveal. The correct answer is A. Impaired gas exchange related to alveolar changes. A is correct because impaired gas exchange names the patient response and identifies an etiology that nursing actions can address through positioning, oxygen suctioning, and pulmonary hygiene. It fits the standard structure of a nursing diagnosis. B is wrong because community-acquired pneumonia is the disease itself, established by the medical team after imaging and cultures. Nurses do not diagnose pneumonia, they manage the human response that the disease creates. C is wrong because hypoxemia is a clinical sign defined by laboratory or oximetry data and falls under the medical diagnosis. While important, it is not a NANDA-style label describing the patient response to illness. D is wrong because streptococcal pneumonia with consolidation describes the organism and the radiographic finding, both medical territory. The nurse acts on the response, such as ineffective airway clearance, not the pathogen identification itself. A medical diagnosis and a nursing diagnosis describe the same patient from 2 different angles, and mixing them up derails the entire care plan. The medical diagnosis names the disease, like pneumonia. The nursing diagnosis names the patient's response to it. the human problem a nurse can treat independently. An actual nursing diagnosis has three parts. First, the problem, a standardized label like impaired gas exchange. Second, the etiology, joined by related to, such as alveolar capillary membrane changes. Third, defining characteristics, joined by as evidenced by, like an oxygen saturation of 88% and confusion. Picture a patient with pneumonia in the right lower lobe. The chest film and culture establish the disease, but the nurse sees labored breathing, a saturation of 90% and crackles. Framing impaired gas exchange related to alveolar capillary changes, as evidenced by that low saturation and abnormal lung sounds. Exam writers test whether you can sort four lookalikes about the same patient: community-acquired pneumonia and streptococcal pneumonia with consolidation are medical diagnoses. Hypoxemia is just a sign, an objective measurement. Only impaired gas exchange paired with a nurse-addressable cause is the true nursing diagnosis. The etiology matters because it aims the intervention, so tie the response to the mechanism, not the disease name itself. Ask who treats it and how. A physician with drugs or surgery means medical. A nurse with positioning and monitoring means nursing. Question 7. A patient admitted yesterday with a stroke now has a wet, gurgling cough during meals and a watery voice afterward. The patient also has chronic arthritis pain rated 3 of 10 and reports loneliness. The nurse must select the highest priority nursing diagnosis from these cues. Your options are A. Chronic pain related to arthritis. B. Social isolation related to hospitalization. C. Deficient knowledge about stroke recovery. D. Risk for aspiration related to dysphagia. Don't overthink it. Which one feels right? The correct answer is D. Risk for aspiration related to dysphagia. D is correct because risk for aspiration outranks the other options because a single aspiration event can produce pneumonia or asphyxia. Airway protection comes first, and the dysphagia cues here mark immediate, severe danger to the patient. A is wrong because chronic pain at 3 of 10 is real but not life-threatening. Pain management matters for comfort, but it does not override an active threat to the airway from the patient's new swallowing problem. B is wrong because social isolation reflects an emotional need that fits lower on Maslow's hierarchy. The nurse must address physiologic threats first. Loneliness can be supported once the patient is medically safe to swallow. C is wrong because deficient knowledge about recovery is important for discharge but not urgent right now. Teaching has no benefit if the patient suffers an aspiration event today, so airway risk takes priority over learning needs. Not every nursing diagnosis describes a problem that already exists. A risk diagnosis names a problem the patient is vulnerable to developing, so the nurse can act before it ever happens. An actual diagnosis has 3 parts, ending in defining characteristics. The signs proving the problem exists now. A risk diagnosis only has 2 parts because there are no symptoms of something that hasn't happened yet. Instead, it carries risk factors, the conditions that make the problem likely. Take risk for aspiration related to dysphagia. Aspiration means food or liquid entering the airway instead of the esophagus, and it hasn't happened yet, so it's a risk. Dysphagia, difficulty swallowing, is the risk factor, and it shows up as a wet or gurgling voice, coughing during meals, food pocketing, a delayed swallow, or drooling. A risk diagnosis is not automatically lower priority than an actual one. Priority depends on severity and immediacy. Aspiration can seed pneumonia or cause asphyxia within minutes, so it outranks slower, less lethal actual problems like chronic pain or loneliness. On the stroke patient coughing at lunch, the wet voice signals risk for aspiration related to dysphagia, and that outranks the arthritis pain and the loneliness until the airway is safe. A risk diagnosis says a problem is coming. An actual diagnosis says it's here and proves it. Question 8. A patient 4 hours post-operative from abdominal surgery reports incision pain at 8 of 10, refuses to ambulate, takes only shallow breaths, and is hesitant to use the incentive spirometer. The nurse must pick the nursing diagnosis most strongly supported by the gathered cues. Your options are A. Risk for falls related to surgery, B. Ineffective coping related to hospital stay, C. Acute pain related to surgical incision, D. Disturbed body image related to scarring. Got a guess? Lock it in. The correct answer is C. Acute pain related to surgical incision. C is correct because the cluster of high pain rating, guarding, refusal to ambulate, and shallow breathing all point directly at acute pain. The defining characteristics fit the diagnosis cleanly, and pain is driving every other finding. A is wrong because risk for falls is plausible, but no false cues are present in this stem. Without unsteady gait, sedation, or attempts to climb out of bed, there is no support for naming this the priority. B is wrong because ineffective coping has no defining cues here, since the patient has not voiced fear, anger, or maladaptive behaviors. The nurse cannot assign coping concerns based only on a refusal driven by physical pain. D is wrong because disturbed body image requires statements from the patient about appearance or scarring, none of which appear here. The cues all point to physiologic pain, not psychosocial concerns about how the body looks. Choosing a nursing diagnosis isn't about picking the label that sounds most serious. It's about evidence, the patient's own cues called defining characteristics that match the diagnosis. The method is cue clustering. A nurse rarely faces one finding but a handful, and the skill is grouping the ones that belong together to see what shared problem they point to. Tightly grouped cues make strong evidence, scattered ones make weak evidence. Watch the cues converge. A post-operative patient reports incision pain at 8 of 10, refuses to walk, breathes in shallow sips, and avoids the spirometer. Every finding is a defining characteristic of acute pain, all pointing to the same answer. Other diagnoses might sound plausible, but they have no cues in this picture. Risk for falls needs an unsteady gait or sedation. Ineffective coping needs fear or anger. Disturbed body image needs comments about appearance. None of that appears here. Naming acute pain correctly points the nurse straight at the real risk. Shallow breathing and immobility set up atelectasis and pneumonia. A well-supported common diagnosis beats an impressive sounding one with nothing behind it every time. Question 9. A confused older adult with chronic mild incontinence is attempting to climb out of bed despite an unsteady gait, was given an opioid 1 hour ago, and has reddened skin over the sacrum that blanches with pressure. The nurse must select the highest priority nursing diagnosis. Your options are A. Impaired skin integrity related to moisture, B. Falls risk from confusion and sedation, C. Functional urinary incontinence chronic pattern, D. Disturbed thought processes related to age. Which one is it? Pause the video if you need more time. The correct answer is B. Falls risk from confusion and sedation. B is correct because an imminent severe risk outranks slower developing actual problems. Climbing out of bed while sedated and unsteady creates a high chance of fracture in the next minutes, so prevention takes priority over comfort issues. A is wrong because skin redness that blanches is stage 1 risk for breakdown, not yet impaired skin integrity. Even if the diagnosis applied, a fall in the next minute would cause more immediate and severe harm. C is wrong because chronic incontinence is a long-standing baseline issue, not a sudden new threat. The diagnosis is real but stable. The patient will not be hurt in the next moment by ongoing urinary patterns. D is wrong because disturbed thought processes describe a contributing factor more than the chief priority itself. The nurse must act on what the confusion will cause, namely a fall, rather than the cognitive change in isolation. When one patient has several problems at once, priority goes to whichever harm is both severe and about to happen. A grave risk that could strike in the next minute outranks a real problem that develops slowly over days. A fall is the classic test of this rule. Unlike a pressure injury or infection that develops gradually with time to intervene, a fall happens in a single second. And that combination of high severity with almost no warning pushes fall risk to the top of the list. Fall risk builds from stacked factors: confusion, an unsteady gait, a recent opioid dose, and a patient actively climbing over the side rail. When these pile up in one person who is already moving, the danger stops being theoretical and becomes an event seconds away. Picture a confused older adult, sedated from an opioid given an hour ago, swinging a leg over the side rail with a gait too unsteady to stand safely. Faint, blanchable redness at the sacrum and a history of mild incontinence are present too, but neither can cause harm in the next 60 seconds. Confusion is a contributing factor, not the priority itself, because what it's about to cause is a fall. Priority reflects both how bad the harm would be and how soon it would arrive. And a fall in the next minute is about as imminent as harm gets. Question 10. A patient with congestive heart failure has a respiratory rate of 28, crackles in both lung bases, dyspnea on minimal exertion, 2+ patent edema, and a skin tear on the elbow without bleeding. The nurse must rank the diagnoses to plan the next hour of care. Your options are: A. Impaired gas exchange related to alveolar fluid. B. Risk for skin breakdown from edema. C. Activity intolerance related to chronic illness. D. Excess fluid volume related to heart failure. Take a second. Which answer would you pick? The correct answer is A. Impaired gas exchange related to alveolar fluid. A is correct because impaired gas exchange fits airway and breathing priority and is the most active acute threat. The crackles, tachypnea, and dyspnea all signal that oxygenation is compromised right now and needs urgent attention. B is wrong because risk for impaired skin integrity is potential, not actual, and develops over hours to days. While edema raises the risk, the threat is not as immediate as the active oxygenation problem at the bedside. C is wrong because activity intolerance is a real concern in heart failure, but does not rise above breathing difficulty. The nurse can address activity limits later. Correcting hypoxia and ventilation comes first using ABC priorities. D is wrong because excess fluid volume is the underlying issue producing the cues, but the ABC consequence is what the nurse treats first. Volume management follows once oxygenation has been stabilized through positioning and oxygen. Congestive heart failure creates several problems at once, and the nurse must decide which to treat first. The same airway, breathing, and circulation ranking that guides every priority question applies here, even when the most urgent problem isn't the root cause. When the left side of the heart fails to pump forward, pressure backs up into the lungs. Fluid leaks out of the capillaries and into the alveoli, the air sacs where oxygen is supposed to cross into the blood, and that fluid becomes a barrier oxygen struggles to cross. The findings tell the story. A respiratory rate of 28, crackles at both lung bases, and dyspnea on minimal exertion. Together these point to oxygenation failing right now, a breathing problem, which sits at the very top of the priority order. Excess fluid volume is the true underlying cause, but priority isn't about what's most fundamental, it's about what harms the patient soonest. Fluid is fixed with diuretics over hours. Impaired gas exchange threatens the brain and heart within minutes. Skin tears, skin breakdown risk, and activity intolerance all matter, but they develop over hours or days, not minutes. Whenever a cause and its breathing consequence appear together, treat the oxygen threat first, then treat what caused it. Question 11. A nurse is planning care for a patient who had abdominal surgery yesterday with a nursing diagnosis of acute pain. The nurse needs to write an expected outcome that meets every part of the SMART framework, with measurable behavior, time anchor, and clear evaluation point at the bedside. Your options are: A. Patient will feel better during this stay. B. Nurse will give pain medication on time. C. Patient will understand pain at discharge. D. Patient reports pain for within 30 minutes. Before I reveal it, which one do you think is right? The correct answer is D. Patient reports pain for within 30 minutes. D is correct because this outcome is specific, measurable, time-bound, and patient-centered. The nurse can compare a numeric pain rating before and after analgesic, evaluate at 30 minutes, and decide whether to revise the plan. A is wrong because feeling better is vague and cannot be measured at any clear moment in time. There is no number, no time frame, and no observable behavior, so the outcome cannot be evaluated objectively at any point. B is wrong because this sentence describes a nursing intervention rather than a patient outcome. SMART outcomes always start with the patient as the subject and describe what the patient will feel, do, know, or demonstrate. C is wrong because understand pain is not measurable, since understanding has no observable form. Teach-back behavior or numeric pain ratings would be measurable. Vague comprehension language gives the nurse nothing to evaluate at discharge. An expected outcome is the measuring stick a nurse writes before care even begins, stating exactly what the patient will look like, sound like, or report if the plan works. Without it, evaluation becomes guesswork. The letters of SMART hold the idea together. Specific names, one clear behavior, measurable attaches a number, attainable fits the patient's real condition, relevant connects to the diagnosis, and time-bound sets a deadline for the nurse to return and check. The subject of a real outcome is always the patient, never the nurse. A sentence starting with what the nurse will do describes an intervention, not an outcome. And this mix-up is the trap exam writers plant most often. A goal like the patient will feel better has no number and no clock, so it can never be confirmed. Compare that to pain at or below 4 within 30 minutes of medication, or trading understand for demonstrate correct use of the incentive spirometer, invisible states turned into visible checkable actions. Signal words like reports, verbalizes, demonstrates, and ambulates, paired with a specific time, mark a measurable expected outcome. It's the promise written at the start, specific enough to later be kept or broken in plain sight. Question 12. A nurse on the medical surgical unit is reviewing the plan of care for a stable patient with impaired gas exchange. The nurse identifies which interventions can be initiated without a provider order. The patient is alert, has stable vital signs, and is on continuous oxygen therapy. Your options are: A. Administer intravenous antibiotic dose now. B. Order chest X-ray for new dyspnea. C. Raise head of bed and encourage spirometry. D. Insert urinary catheter to monitor output. What's your answer? Commit to one before I continue. The correct answer is C. Raise head of bed and encourage spirometry. C is correct because repositioning and encouraging incentive spirometry are independent nursing actions. Both improve ventilation, are within standard nursing scope, and do not require a provider order before implementation in a stable patient. A is wrong because administering an antibiotic requires a provider order, since the medication, dose, route, and frequency are decided by the prescriber. The nurse implements the order but does not initiate it independently. B is wrong because ordering imaging is outside the registered nurse scope of practice in most settings. The nurse may suggest the test during communication with the provider, but only the prescriber can write the order. D is wrong because inserting a urinary catheter is a dependent intervention requiring a written order in nearly every facility. Catheter insertion also carries infection risk, which is exactly why prescriber involvement is necessary first. Every intervention in a care plan has to trace back to the diagnosis it treats. For impaired gas exchange, that means one job only: move more oxygen in and clear more carbon dioxide out. Impaired gas exchange means a breakdown at the alveolar capillary membrane, the thin border where oxygen enters the blood and carbon dioxide leaves it, fluid, collapsed alveoli, thick secretions, or shallow breathing all widen that gap. So any real intervention has to attack one of those mechanisms. Raising the head of the bed to halve Fowler's uses, gravity to drop the organs away from the diaphragm, letting the lung bases expand. Incentive spirometry has the patient inhale deeply against a target, reopening alveoli that shallow breathing let collapse. Both are within independent nursing scope and both directly widen gas exchange. Contrast that with actions outside independent practice, hanging an IV antibiotic or ordering a chest film, both require a prescriber's decision. And watch for the sharper trap, a real nursing action aimed at the wrong problem, like inserting a urinary catheter to track output. It does nothing for the alveoli. So ask one question of every choice: does this move oxygen or clear carbon dioxide? Position and lung expansion come first, then coughing to clear secretions, then pacing activity, so demand never outruns supply. Keep the alveolar capillary membrane in mind, and you'll always spot the action that treats breathing versus the one that just looks busy. Question 13. A nurse is planning care for a patient 3 days after a stroke who is having difficulty swallowing thin liquids and has a wet voice after sips of water. The plan must include an action that involves coordinating with another discipline to evaluate safe oral intake. Your options are: A. Consult speech-language pathologist for swallow study. B. Place nasogastric tube to bypass swallowing. C. Document swallowing trouble and continue diet. D. Reassure patient that swallowing improves later. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Consult speech-language pathologist for swallow study. A is correct because a speech-language pathology consult fits a true collaborative intervention and brings expert evaluation of swallow safety. The pathologist guides diet, texture, and feeding strategies that prevent aspiration in the recovering stroke patient. B is wrong because placing a nasogastric tube requires a provider order and skipping the swallow work-up oversteps assessment. The team should evaluate swallowing first to determine whether oral intake can be made safe. C is wrong because charting alone leaves a high-risk situation unchanged. Continuing the current diet without a swallow evaluation puts the patient at serious risk for aspiration pneumonia, which the nurse must prevent through team referral. D is wrong because verbal reassurance does not address the danger of aspiration during the next meal. Comfort statements have value alongside action, but they cannot replace the formal swallow evaluation needed for safety. Some nursing interventions can't be done by the nurse alone, and they aren't simply physician orders either. These are collaborative or interdependent interventions, where the nurse recognizes a problem and pulls in the right specialist. A swallow evaluation after a stroke is the classic example. A stroke can weaken the muscles and nerves that control swallowing, causing dysphagia. Thin liquids are hardest to control, and when they slip past protective reflexes into the lungs, the result can be aspiration pneumonia. A wet, gurgly voice signals pooling liquid, while silent aspiration is even more dangerous because there's no cough to warn the nurse at all. The speech-language pathologist is trained to evaluate swallowing using a bedside screen and, when needed, a modified barium study to see exactly where the swallow breaks down. From that evaluation come specific recommendations, like thickened liquids that move slowly enough for a weak swallow to protect the airway, or a chin tuck that redirects food safely. Acting alone is the trap. Placing a feeding tube is a dependent order that skips the very evaluation deciding if the patient can eat safely. Charting and continuing the diet leaves a known risk unaddressed and kind reassurance, while caring is not action and protects no one from the next sip. A collaborative intervention means the nurse who screens, hears the wet voice, holds the diet, and calls for a swallow consult is practicing skilled independent judgment while reaching for the right partner. That combination is what keeps a recovering stroke patient safe. Question 14. A nurse is writing care plan goals for a frail 88-year-old patient recovering from a hip repair. The nurse must choose an outcome that is realistic, patient-centered, and individualized to the patient's baseline and tolerance level rather than a copy from a textbook for younger adults. Your options are: A. Patient runs a mile day 3. B. Nurse will encourage ambulation each shift. C. Patient will return to baseline strength. D. Patient walks to chair with assistance today. Which would you go with? Lock it in before the reveal. The correct answer is D. Patient walks to chair with assistance today. D is correct because walking to the chair with assistance suits the patient's frailty and recent surgery while still pushing a measurable, time-bound action. The outcome is realistic, individualized, and tied to clear bedside observation today. A is wrong because running a mile by day 3 is unrealistic for any post-hip repair patient, and especially unsafe for a frail older adult. The outcome ignores the actual recovery trajectory and protective weight-bearing limits. B is wrong because nurse will encourage ambulation describes an intervention, not an outcome. Smart outcomes are written from the patient's viewpoint and describe what the patient will accomplish, feel, or demonstrate during the shift. C is wrong because return to baseline strength is too vague and lacks a measurable time anchor or observable behavior. Without numbers or an evaluation point, the nurse cannot decide whether the goal has been met today. A goal can be perfectly measurable and still be wrong if it asks more than a particular patient's body can give. Attainable and individualized travel together, and this is where clinical judgment does its quietest work. To individualize a goal, the nurse first has to know the baseline, what the patient could do before this illness or surgery, how far they walked at home, whether they used a cane or a walker, and how much help they needed with daily tasks. A frail patient in their 80s does not start from the same place as a fit 50-year-old with the same surgery. Consider a patient 2 days after a hip repair. A goal that says the patient will run a mile by day 3 is dangerous, ignoring protective weight-bearing limits. A goal that says the patient will return to baseline strength sounds kinder, but has no number and no clock, so no one can ever confirm it was reached. A goal that fits reads like this: the patient will walk from the bed to the bedside chair with the assistance of one person before the end of the shift. It names a distance a healing hip can manage, allows the help a frail body still needs, and stays measurable within a single shift. First confirm the patient is the actor, then ask whether the goal is honestly within reach today. The best outcomes for a frail elder are small, concrete, and stepwise. Each one a rung the patient can actually reach before the next is set. Question 15. A nurse is updating the fall prevention plan for a confused patient who repeatedly attempts to climb over the side rails to reach the bathroom. The nurse seeks the most individualized intervention rather than a generic statement that could apply to any patient on the unit. Your options are: A. Place call light within easy reach. B. Keep the bed in low position. C. Offer scheduled toileting and bedside commode. D. Educate family about general fall prevention. Don't overthink it. Which one feels right? The correct answer is C. Offer scheduled toileting and bedside commode. C is correct because scheduled toileting and a bedside commode address the actual driver of the unsafe behavior, which is the urge to reach the bathroom. The intervention is tailored to this patient's specific cue and need. A is wrong because call light placement is a generic universal precaution applied to every patient on the unit. While useful, the confused patient will not consistently use the call light, so the action does not solve this problem. B is wrong because a low bed position is part of universal fall precautions for all patients. It helps reduce injury but does not address why this particular patient keeps trying to climb out repeatedly. D is wrong because family education has long-term value but does not change behavior tonight. The nurse needs an immediate intervention that meets the patient's elimination need before climbing happens, not a teaching plan for later. Fall prevention actually has 2 layers, and mixing them up is one of the most common test-taking mistakes. The first layer is universal precautions, applied to every at-risk patient: the bed in its lowest position, a call light within reach, non-skid footwear, and a clear path to the bathroom. These are good practice, but they assume a patient can still reason and remember to use them. Picture a confused patient repeatedly climbing over the side rails. The universal precautions are already in place, yet the climbing continues, because the real driver is a full bladder, a powerful urge acted on by a brain that can no longer plan the safe route. Once the nurse names the driver, the fix almost writes itself: scheduled toileting every 2 hours, or a bedside commode kept close, so the urge never builds to the point of an unsafe climb. On exam day, watch for words like individualized and specific, and for any detail about what the patient repeatedly does. The universal precautions are never wrong, but the correct answer is the one built around this patient's own reason for being at risk. Question 16. A nurse is preparing to administer the morning insulin dose to a patient with diabetes. The chart lists an allergy to a related drug class. Before drawing up the dose, the nurse decides the safest verification step to prevent a medication error during this routine task at the bedside. Your options are: A. Trust the previous nurse's note completely. B. Confirm the patient identifies an allergy. C. Skip identifier check for known patient. D. Ask the family to confirm the dose. Got a guess? Lock it in. The correct answer is B. Confirm the patient identifies an allergy. B is correct because verifying 2 patient identifiers and reviewing allergies before any medication is the universal safety standard. This step catches near misses caused by misfiled charts, similar names, or undocumented allergic reactions to previous drugs. E is wrong because trust without independent verification has produced many serious errors, including wrong patient and wrong dose events. The current nurse remains responsible for confirming details rather than relying on a colleague's prior charting. C is wrong because skipping identifier checks for familiar patients undermines the entire 2 identifier safety practice. Familiarity is exactly the condition under which look-alike errors slip through, which is why the rule applies every time. D is wrong because family confirmation is helpful but does not replace the formal verification of identifiers and allergies through the chart and patient. Family members may not know specific allergy details with full accuracy. Before a single drop of medication is drawn up, every nurse performs the same 2 checks every time, confirming who the patient is and confirming what they're allergic to. These simple steps stand between a routine task and some of the most serious errors in healthcare. 2 identifiers means a full name and a date of birth. verified by asking the patient to state them, then comparing against the wristband and chart. A single identifier can collide, since hospitals often hold several patients with the same last name, so one check alone is a coincidence waiting to cause harm. The allergy check reaches further than the exact drug on the label, because allergies cross whole families of medication. Insulin makes the stakes concrete. It's a high alert drug where a missed cross-reaction can drop blood sugar to a dangerous low. So the nurse weighs the dose against the allergy record and the patient's history with related products. Every shortcut here shares one root: trust, standing in for verification, accepting a colleague's note, dahi inside ikawi sorry, skipping the check because a patient is familiar, or leaning on a family member's word, all trade a guaranteed safeguard for a guess. And the guess sometimes guesses wrong. A near miss caught at this step looks like nothing at all. Just a normal medication pass, and that silence is the point. The rule applies on the 1000th dose exactly as it did on the first. Question 17. A nurse evaluates a post-operative patient 1 hour after administering an opioid for pain. The patient now reports pain 3 of 10. Breathing is even and unlabored at 16 per minute, and ambulates short distances in the room with steady gait. The nurse classifies the outcome. Your options are: A. Outcome met as documented and continue plan. B. Outcome not met and revise plan now. C. Outcome partially met and add new diagnosis. D. Outcome no longer relevant and discontinue. Which one is it? Pause the video if you need more time. The correct answer is A. Outcome met as documented and continue plan. A is correct because the patient achieved a measurable pain rating below 5. Breathing remained safe and mobility improved. All elements of the planned outcome are present, so the nurse documents the outcome met and continues current care. B is wrong because outcome not met would require findings that the goal failed, such as continued severe pain or worsening breathing. The data here clearly show success, so revising the plan is unnecessary at this evaluation point. C is wrong because partially met would apply if some elements improved while others did not, such as pain easing while ambulation remained limited. Here, every component improved, so the partial label does not fit the data. D is wrong because outcome no longer relevant only applies when the underlying diagnosis no longer exists. Acute pain still exists at 3 of 10, so continuing reassessment of the same outcome remains appropriate going forward. Evaluation is the step where the nursing process asks a plain question: did the plan work? It is not a feeling or an impression, but a deliberate comparison between the expected outcome written during planning and the actual data gathered right now. Consider a patient with a pain goal after surgery: pain at or below 4 within an hour, safe breathing and improved mobility. The nurse gathers the data: pain rated 3 out of 10, respiratory rate 16 and unlabored, and a steady walk across the room. Every finding is measured against the promise, not judged by mood. Since all 3 pieces improved, the verdict is outcome met, ruling out the others. Not met needs actual failure. Partially met needs some pieces stalling, and no longer relevant needs the diagnosis itself to be gone. A pain rating of 3 is controlled, not gone, so the diagnosis stays active and the outcome remains in force at the next check. When data matches the written outcome, the skilled move is to document the success and let the effective plan continue undisturbed. On exam day, look for hard numbers compared against a written outcome and choose between met, not met, partially met, and no longer relevant based on careful comparison, not a general sense of how the patient seems. Question 18. A nurse administered an antiemetic to a patient reporting nausea 40 minutes ago. The patient asks for a snack and the nurse must decide whether to honor the request. Before offering food, the nurse plans the most important next step within the nursing process cycle. Your options are A. Bring the snack and encourage intake. B. Discontinue the antiemetic from the plan. C. Document only that a snack was given. D. Reassess nausea level and abdomen first. Take a second. Which answer would you pick? The correct answer is D. Reassess nausea level and abdomen first. D is correct because reassessment after every intervention closes the loop in the nursing process. The nurse must confirm the antiemetic worked and that the abdomen tolerates intake before introducing food that could trigger renewed vomiting. A is wrong because bringing the snack without rechecking nausea may cause vomiting if the medication has not yet worked. The nurse cannot assume effectiveness. Reassessment provides the data needed to choose the next step safely. B is wrong because discontinuing the antiemetic from the plan after one dose is premature. The medication may still be needed for breakthrough nausea later in the shift, so removing it from the plan jeopardizes ongoing comfort. C is wrong because documenting that a snack was given without reassessment skips the evaluation step. Charting alone does not protect the patient from aspiration risk if nausea has actually worsened despite the recent medication dose. The nursing process isn't a straight line from assessment to evaluation. It's a loop, and reassessment is the step that closes it, gathering fresh data after every intervention before deciding what to do next. Every intervention is really a prediction. Giving a medication means predicting the drug will work, but that prediction must be tested against the actual patient, because bodies vary and only looking again reveals the truth. Picture a patient who got an antiemetic 40 minutes ago and now wants a snack. Before handing over food, the nurse must recheck the nausea level, listen for bowel sounds, and assess whether the abdomen is soft or distended, because only fresh data proves the medication worked. Every wrong answer skips the step in a different way: handing over food blindly, discontinuing the antiemetic too soon, charting the snack without judgment, or trusting that 40 minutes alone means the drug worked. Reasonable timing is not the same as certainty. The same loop governs everything from repositioning a breathless patient to teaching a new skill. Act, then look back. That look back is what turns tasks into safe, responsive care. Question 19. A new graduate is sorting interventions from the plan of care for a stable patient with impaired skin integrity. The graduate wants to identify the action that is independent and can be initiated without a provider order while still falling within standard nursing scope of practice. Your options are: A. Apply prescribed antibiotic ointment to wound. B. Insert a urinary catheter for output. C. Reposition the patient every 2 hours. D. Initiate intravenous fluids for hydration. Before I reveal it, which one do you think is right? The correct answer is C. Reposition the patient every 2 hours. C is correct because repositioning is an independent nursing action used in pressure injury prevention. It requires no order, falls within standard scope, and directly addresses the diagnosis through redistribution of weight of bony prominences regularly. A is wrong because applying a prescribed ointment requires the provider order that names the medication and frequency. The nurse implements the order but does not select or initiate the antibiotic on personal judgment alone. B is wrong because urinary catheter insertion is a dependent intervention requiring a written order in nearly every facility. Catheter use also carries infection risk, which is part of why prescriber involvement is required first. D is wrong because starting intravenous fluids requires a provider order specifying the solution, rate, and indication. The nurse may suggest the order during communication, but cannot independently begin fluid therapy in standard practice. Every nursing action falls into one of 3 categories, sorted by who holds the authority to start it. Knowing which is which decides whether a nurse can simply act or must first secure an order. Independent interventions are started on nursing judgment alone, with no order required. Dependent interventions require a prescriber's order because the decision belongs to the physician. Collaborative interventions are shared with another discipline, like physical therapy or dietary. Take a stable patient with a reddened area over the tailbone. Turning that patient every 2 hours needs no order. It falls squarely within nursing scope. Lifting sustained weight off the bony prominence so blood can return to the compressed tissue. Change one word and the category changes with it. A prescribed ointment is dependent even though the nurse applies it, because the prescriber chose the medication. Inserting a catheter or starting IV fluids also needs an order. Requesting physical therapy or a dietitian is collaborative, drawing on another profession's expertise. On exam day, ask who decides. If nursing judgment alone justifies the action, it's independent. If it takes a prescriber's authority, it's dependent. If it takes another discipline, it's collaborative. Question 20. A nurse evaluates a patient with a goal of ambulating 50 feet 3 times today and reporting pain at 4 or below after each walk. By the end of the shift, the patient walked 25 feet twice and reported pain 6 after each walk. The nurse classifies the outcome. Your options are A. Partially met and revise interventions. B. Fully met and continue current plan. C. Not met and discontinue mobility goal. D. Not relevant and remove from plan. What's your answer? Commit to one before I continue. The correct answer is A. Partially met and revise interventions. A is correct because some progress occurred, but neither distance nor pain target was reached. The label partially met fits, and the nurse should revise interventions, perhaps by adjusting analgesic timing or shortening walking distance per attempt. B is wrong because fully met would require both the distance and the pain target to be reached. The patient missed both benchmarks. So calling the outcome fully met misrepresents the data and risks inadequate plan revision. C is wrong because not met implies no progress occurred, which is inaccurate here since the patient walked some distance twice. Discontinuing the mobility goal would also remove a clinically necessary postoperative recovery target. D is wrong because the mobility goal remains highly relevant for a postoperative patient, since walking prevents complications like pneumonia and venous thromboembolism. Removing it from the plan would harm the patient's recovery trajectory. Evaluation isn't always a clean yes or no. When a patient moves toward a goal without fully reaching it, the nurse must name that middle ground, partially met, a verdict that always leads to revising the plan, never abandoning or ignoring it. Picture a postoperative goal with 2 measurable targets, walking 50 feet 3 times and pain at 4 or below afterward. By shifts in, the patient walked 25 feet twice with pain at 6. Real progress happened, but neither target was fully reached. Naming the outcome partially met points straight to an action. Revise the interventions. If pain cut walks short, time medication to peak beforehand. If distance was too much at once, break it into shorter, more frequent walks. The goal stays, the path changes. Calling this fully met overstates the result and wrongly freezes a plan needing change. Calling it not met erases real progress. Discontinuing is worst of all. It strips away a clinically necessary mobility goal that fights pneumonia and blood clots, just because it was hard to reach. On exam day, watch for mixed results, real progress that still falls short of the stated numbers. That combination signals partially met, with revision as the required next step. Question 21. A nurse beginning a shift receives report on 4 patients. The nurse must decide which patient to assess first based on stability and acute cues. The nurse uses ABC priorities and acute versus chronic reasoning to choose the most pressing patient on the assignment. Your options are A. Patient with chronic stable arthritis pain. B. Patient sleeping after a settled headache. C. Patient awaiting routine discharge teaching. D. Patient with new shortness of breath. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Patient with new shortness of breath. D is correct because new shortness of breath signals a possible breathing problem, which is a top ABC concern. The cue is acute and unstable, so the nurse must assess this patient first before any of the others. A is wrong because chronic stable arthritis pain represents an established baseline, not an acute change. The patient is not at immediate risk, so the assessment can wait until acutely ill patients have been evaluated. B is wrong because a patient sleeping after a settled headache shows resolution rather than active distress. While the nurse will eventually round, this patient does not signal an urgent change and can wait safely. C is wrong because routine discharge teaching is important but never an emergency. The patient awaiting teaching is stable and safe, so the nurse can pick up that task once urgent ABC concerns have been addressed. Every shift begins with a choice, which patient to see first. That choice is a safety judgment guided by a framework called ABC. Airway ranks first because an obstructed airway kills fastest. Breathing ranks second since oxygen must cross into the blood. Circulation ranks third because the heart has to pump that blood to the tissues. A second filter separates careful choices from hasty ones, acute versus chronic. An acute cue is new or sudden, while a chronic condition is a steady pattern the body has adapted to. New shortness of breath is acute and lands on the B of ABC, so it demands attention now, while long-standing stable pain can wait. Picture 4 patients at 7 in the morning, one with chronic stable joint pain, one whose headache has resolved, one waiting for routine discharge teaching, and one reporting new, worsening difficulty breathing. Only that lost patient has a new cue on the B of ABC, so that is where the nurse goes first. Signal words like new, sudden, and increasing point toward action, while chronic, stable, and resolved mean the patient can safely wait. ABC prioritization always asks the same narrow question: whose body is most immediately threatened right now? Question 22. A nurse caring for several patients must decide which problem ranks highest. One patient reports loneliness, another has new chest pressure with diaphoresis, another has poor self-image, and another asks about future career planning. The nurse uses the Maslow and ABC frameworks together to prioritize action. Your options are A. Loneliness and need for social connection. B. Chest pressure with diaphoresis and concern. C. Negative self-image affecting daily mood. D. Career planning question after discharge. Which would you go with? Lock it in before the reveal. The correct answer is B. Chest pressure with diaphoresis and concern. B is correct because chest pressure with diaphoresis suggests a possible cardiac event, ranking highest under ABC priorities. Physiologic and acute circulatory threats always come before love, esteem, and self-actualization needs in patient prioritization. A is wrong because loneliness sits in the love and belonging tier of Maslow, far below physiologic emergencies. The need is real but does not threaten survival, so it cannot outrank possible cardiac symptoms in any patient. C is wrong because self-image concerns belong to the esteem layer of Maslow, addressed only after physiologic and safety needs are stable. The nurse cannot ethically place an esteem issue ahead of suspected cardiac compromise. D is wrong because career planning belongs to self-actualization, the highest tier of Maslow. Such concerns are valid but never override an active physiologic threat, since survival itself is required before pursuing higher goals. Maslow described human needs as a pyramid, and that pyramid is one of the most useful tools a nurse has for setting priorities. At the base sit physiologic needs like oxygen, water, food, elimination, and sleep, followed by safety, then love and belonging, then esteem, and finally self-actualization at the peak. Lower needs generally must be met before higher ones matter. A brain starved of oxygen cannot worry about friendship, and a person in circulatory collapse cannot think about career goals. Physiologic stability is the platform every other need stands on, which is why airway, breathing, and circulation live at the very bottom and get addressed before all else. Consider 4 patients. One feels lonely, one has a bruised self-image, one is planning a return to work, and one reports chest pressure with a cold sweat. All 4 needs matter, but only the chest pressure signals the body itself may be failing, so that patient is seen first. Loneliness, self-image, and future planning are never trivial, and a skilled nurse folds them into care once the patient is stable. The pyramid isn't about ignoring the top tiers. It's about sequencing care when something at the base is threatened. Question 23. A nurse caring for an alert older adult must rank current problems. The patient has acute pain at 7 of 10, a low score on the full risk screen, dry mucous membranes, and reports mild loneliness. The nurse uses the actual versus risk and ABC frameworks to prioritize. Your options are A. Mild loneliness while in hospital, B. Risk for falls based on screening, C. Acute pain rated 7 of 10, D. Risk for boredom during admission. Don't overthink it. Which one feels right? The correct answer is C. Acute pain rated 7 of 10. C is correct because acute pain is an actual current problem with a high rating that drives many other complications. Untreated severe pain affects breathing, mobility, and recovery, so the nurse addresses this real issue first now. A is wrong because mild loneliness is real but emotional and lower on Maslow than acute pain. The need can be addressed alongside other care once the more pressing physiologic discomfort has been treated and is decreasing. B is wrong because risk for falls is a potential problem and the screening score is low, suggesting limited urgency. Risk diagnoses generally yield to actual problems with active cues unless the risk is imminent and severe. D is wrong because risk for boredom is not even a typical priority diagnosis on a busy unit. It pales in comparison to severe acute pain that is actively impairing function and recovery for this patient right now. When every patient on the floor is stable, prioritization shifts. The nurse now ranks problems, not patients, using 2 ideas together: actual versus risk and severity. An actual problem is present right now, something the patient reports or the nurse can measure. A risk problem is only a possibility, raised odds without an active finding. As a rule, actual outranks risk because a nurse treats what is happening before what might happen. Severity sorts actual problems among themselves. Pain rated 7 of 10 reaches far beyond the site of injury. It causes shallow breathing that lowers oxygen and invites pneumonia. It keeps the patient still, raising clot and pressure injury risk, and it disrupts sleep, appetite, and healing. Picture a stable woman in her 70s with 4 things true at once: severe hip pain, a low full risk score, dry mucous membranes, and mild loneliness. The pain is the severe active physiologic threat, so it is treated first while hydration, loneliness, and routine fall precautions follow alongside it. This is different from ABC, which chooses among unstable patients. Here, every patient is safe for the moment, so the nurse ranks by acuity: actual before risk, severe before mild. Question 24. A registered nurse on the medical surgical floor must complete several tasks during the shift. The nurse considers which task can be assigned to the unlicensed assistive personnel, since some require independent assessment and clinical judgment beyond the assistive personnel scope of practice today. Your options are A. Recording vital signs on a stable patient, B. Teaching insulin self-injection to a patient. C. Performing an admission head-to-toe assessment. D. Adjusting an intravenous infusion rate. Got a guess? Lock it in. The correct answer is A. Recording vital signs on a stable patient. A is correct because recording vital signs on a stable patient sits squarely within unlicensed assistive personnel scope. The task is routine, predictable, and requires no nursing judgment, making it safe to delegate during the shift. B is wrong because teaching insulin self-injection requires the registered nurse because patient education involves assessment of learning, evaluation of return demonstration, and clinical judgment. Assistive personnel cannot perform that level of teaching. C is wrong because an admission head-to-toe assessment is a registered nurse responsibility that establishes baseline clinical data. The judgment and physical assessment skills required exceed unlicensed assistive personnel scope of practice anywhere. D is wrong because adjusting an intravenous infusion rate is a licensed nurse task, often a registered nurse one. Unlicensed personnel cannot manipulate medication delivery devices because errors carry serious patient safety consequences immediately. Delegation separates a new nurse from a confident one, and it rests on one clear principle. You can hand off a task, but never the accountability for it. When a nurse delegates to unlicensed assistive personnel, or UAP, the nurse still owns the outcome. The profession organizes safe delegation around 5 rights: the right task, the right circumstance, the right person, the right direction and communication, and the right supervision. Skip any one of these and delegation becomes unsafe. Picture a nurse with 4 jobs: routine vital signs on a settled patient, insulin teaching, an admission assessment, and an IV drip change. Only the vital signs move to the assistant. The teaching, assessment, and infusion change all require the license. Anything requiring the nursing process, assessment, diagnosis, planning, evaluation, plus teaching and clinical judgment cannot be delegated. The reliable test is whether the task needs a nurse's judgment at any point. If it does, it stays with the nurse. Delegation isn't about prioritizing what happens first. It's about deciding who should do it and whether it can be handed off at all. A nurse who delegates well matches routine work to the right person while keeping every act of judgment under a license. Question 25. A nurse rounds on 3 patients. One has chronic moderate constipation. One has stable post-op pain at 4 of 10 with a regular medication. And one is neutropenic and just received a first dose of antibiotic with mild cough. The nurse must select the highest priority action. Your options are: A. Reposition constipated patient and offer fluids. B. Administer the next scheduled pain medication. C. Document all stable findings carefully. D. Monitor neutropenic patient for infection cues. Which one is it? Pause the video if you need more time. The correct answer is D. Monitor neutropenic patient for infection cues. D is correct because A. Neutropenic patient with new cough faces imminent severe infection risk. Even subtle cues may signal bacteremia. So close, monitoring outranks comfort tasks because untreated sepsis can deteriorate quickly into shock. A is wrong because constipation management matters but is chronic and stable. Repositioning and fluids can wait while the nurse evaluates a patient who is at far higher risk for life-threatening systemic infection right now. B is wrong because scheduled pain medication for stable post-op pain is routine and not time critical to the minute. The nurse can administer that dose once the higher risk neutropenic patient has been carefully assessed first. C is wrong because documentation is necessary, but never the highest priority when an unstable risk situation exists. Charting waits while the nurse responds to the patient with the most imminent and severe potential harm. Neutrophils are the immune system's first responders to bacteria, and neutropenia means having too few of them to mount a defense. Chemotherapy is a common cause, because it wipes out the fast-growing marrow cells that make neutrophils along with the cancer. The danger isn't just easier infection, it's that the usual warning signs of fever, redness, swelling, and pus all depend on neutrophils to appear. With few neutrophils, a serious infection like pneumonia can advance while showing almost nothing, sometimes just a mild cough. And even fever can be blunted. Picture the same infection site with and without enough neutrophils on patrol. Normally they trigger fever, redness, swelling, and poos. Without them, that same infection can smolder almost invisibly. Consider 3 patients, one with chronic constipation, one with well-controlled post-operative pain, and one who is neutropenic after chemotherapy with a new mild cough. The first 2 are real but stable problems. The third is a faint signal of a threat that could turn into septic shock within hours, so that patient is assessed first. This overturns the usual rule that an actual problem outranks a risk. In neutropenia, the risk is so imminent and severe that a mild cough demands attention before stable comfort needs that can safely wait. Question 26. A nurse working the evening shift on a busy medical surgical unit is reviewing universal fall precautions for every patient. The nurse picks the action that should be in place for all patients regardless of risk score, since falls remain a leading cause of preventable inpatient harm. Your options are: A. Apply soft wrist restraints at bedtime. B. Place all patients in side-lying position. C. Keep call light and items within reach. D. Order a sitter for every patient nightly. Take a second. Which answer would you pick? The correct answer is C. Keep call light and items within reach. C is correct because keeping the call light and personal items within reach is part of universal fall precautions for every patient. The action prevents reaching, climbing, and unsafe transfers regardless of formal risk screen score. A is wrong because wrist restraints are not a universal fall precaution and require an order plus failed least restrictive alternatives. Restraints can actually increase fall injury severity if a patient still attempts to move. B is wrong because side-lying position is sometimes used for aspiration risk, but is not a universal fall precaution. Many patients require head-of-bed elevation or upright positioning, so this is not appropriate for everyone. D is wrong because continuous sitter use for every patient is impractical and not standard. Sitters are reserved for patients with documented unsafe behavior or impaired judgment, not as a universal precaution on the unit. Falls are one of the most common preventable harms in a hospital, so nurses don't wait to find out who's high risk before acting. A baseline set of protections goes to every patient on the unit regardless of age, diagnosis, or fall risk score. The idea behind universal precautions is simple. Any patient can fall. A person weakened by illness, groggy from medication, or unfamiliar with a dark hospital room can go down even without a formal risk factor. So nurses apply the same baseline measures to everyone. The core of universal precautions is keeping the patient's world within safe reach. The call light and personal items stay close. The bed sits low with wheels locked. The path to the bathroom is clear and lit, and non-slip footwear goes on before walking. The distinction that matters is what counts as universal. A low locked bed and a reachable call light apply to everyone, but restraints require an order and can increase injury, and a sitter at every bedside isn't practical or standard. Those are targeted measures, not universal ones. Universal precautions are what every patient gets first before any risk score is even calculated. Stratification then adds extra layers for those who need them most, but the baseline itself never gets skipped. Question 27. A nurse reviewing the evening assignment must identify the patient at highest risk for a fall. Each patient has different histories and current status. The nurse uses common fall risk factors such as age, sedation, mobility, recent fall history, and cognitive change to choose the most vulnerable patient. Your options are A. 80-year-old confused after recent opioid. B. 40-year-old ambulating without difficulty. C. 30-year-old preparing for routine discharge. D. 50-year-old sleeping with steady vitals. Before I reveal it, which one do you think is right? The correct answer is A. 80-year-old confused after recent opioid. A is correct because old age, new confusion, and recent opioid sedation combine multiple major fall risk factors at once. The patient is the most likely to fall and needs targeted prevention measures rather than universal ones. B is wrong because a 40-year-old who is ambulating without difficulty has no major risk factors for falls. The nurse still applies universal precautions, but the targeted prevention plan is not necessary for this patient. C is wrong because a 30-year-old preparing for routine discharge is generally stable and at low fall risk, without sedation, mobility deficit, or cognitive change. The screening would not place the patient at high risk. D is wrong because a 50-year-old asleep with steady vital signs is currently stable and low risk while in bed. The nurse will monitor on rounds, but no targeted high-risk fall plan applies right now to the patient. Universal precautions go to every patient, but stratification is how a nurse figures out who needs more than the baseline. It works by identifying and weighing the factors that make one patient more likely to fall than the person next door. The major risk factors are worth knowing cold. Advanced age weakens muscles and bones. Cognitive change hides danger from the patient. Sedating medications blunt alertness. Mobility problems raise the odds directly. A recent fall predicts the next one. And urgent toileting or poor vision add further hazard. What makes a patient's highest risk is not one factor, but several stacking at once. An older patient who is newly confused and freshly sedated carries three major factors together, each multiplying the others, which earns a bed alarm, hourly rounding, and closer supervision. A sleeping patient with steady vitals looks calm, but the real test is what happens the moment they wake and try to move. The nurse learns to read the standing factor list, not just the present snapshot. Universal precautions ask what everyone gets. Stratification asks who, based on their standing factors, needs more. Scan for signal words like confused, sedated, and unsteady, and find the patient carrying the heaviest load. Question 28. A confused older adult patient is climbing over the partial side rail of the bed and reaching for the window. The nurse considers what to do next. Knowing that side rails can sometimes increase fall injury rather than prevent harm when the patient is determined to get out. Your options are A. Raise all four side rails up. B. Lower bed sit, address patient need. C. Apply a vest restraint over chest. D. Chart that bed is in low position. What's your answer? Commit to one before I continue. The correct answer is B. Lower bed, sit, address patient need. B is correct because lowering the bed, providing a one-to-one presence, and addressing the underlying needs such as toileting or pain reduces both the urge to climb and injury severity if a fall occurs. A is wrong because raising all four side rails functions as a restraint and increases injury height when the patient climbs over. Many serious falls occur when the patient tumbles over rails to reach the floor. C is wrong because a vest restraint should not be applied without exhausting less restrictive alternatives and obtaining an order. Restraints have caused asphyxia and entrapment, especially in confused patients who continue trying to move. D is wrong because documenting the bed setting alone does not address the active climbing behavior. The nurse must intervene first by being present and meeting the underlying need, then chart the action and patient response. When a confused patient tries to climb out of bed, The instinct to raise all four rails or reach for a restraint is exactly backwards. The safest response goes the other way, toward the least restrictive action that solves the real problem. Climbing usually signals an unmet need, like a full bladder, pain, hunger, thirst, fear, or disorientation. So the first move is to lower the bed, come to the bedside, and stay present while finding out what the patient actually needs. Raising all four side rails turns them into a restraint because the patient can't lower them and often climbs over anyway. That means the fall now starts from the top of a raised rail instead of a low mattress, landing harder and causing more serious injury. Restraints sit even further down the wrong path, requiring a provider's order and documented proof that gentler options were tried first. They can increase agitation and have caused strangulation or entrapment, so using one to quiet a climbing patient inverts the entire least restrictive principle. Charting a low bed position isn't an intervention, it's just a description while the patient keeps climbing. Act first by lowering the bed, staying present and meeting the need, and only then chart what was done and how the patient responded. Question 29. A nurse hears a thud and finds a patient on the floor next to the bed. The patient is alert and reports right hip pain. The nurse recognizes that a fall has occurred and considers the most important first action before transferring the patient back to bed. Your options are A. Help patient stand and walk back. B. Lift the patient quickly to chair. C. Move patient to bed and chart later. D. Assess injury and vitals before moving. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Assess injury and vitals before moving. D is correct because assessing for injury, level of consciousness, and vital signs before moving the patient is the standard post-fall response. Lifting too soon can worsen a hidden fracture, head injury, or hemodynamic problem. A is wrong because helping the patient stand and walk before assessment risks worsening any fracture or head injury. The nurse must rule out spinal, hip, or limb injury before encouraging weight bearing on a possibly fractured limb. B is wrong because lifting quickly to a chair before assessment carries the same risk of converting a stable injury into a worse one. The nurse holds the patient still until injury status is clear and safe. C is wrong because moving without assessment and saving the chart for later both miss safety steps. The first priority after a fall is the patient evaluation. Documentation follows after the patient has been protected and treated. The moment after a fall is when good instincts can cause harm. Every urge says lift the patient up and restore order, but that instinct has to be overridden. Because the single most important action after a fall is to assess before moving at all. A fall can produce injuries that are invisible from across the room and easy to worsen with movement. A hip may be fractured, the spine may be unstable, a head strike may be bleeding slowly inside the skull, and a patient whose blood pressure just dropped can fall again if stood up too soon. The assessment happens right there on the floor where the patient landed. The nurse checks responsiveness, airway, breathing, and circulation, then surveys for pain, deformity, bleeding, and the ability to move arms and legs, and takes vital signs before deciding anything about a transfer. The tension here is compassion pulling against safety. Helping a patient up quickly feels kind, but lifting first, chairing first, or charting before assessing all skip the one step that matters. The order is fixed. Evaluate, protect, then move, then document. A few extra minutes on the floor costs little. Converting a hidden fracture or spinal injury into something catastrophic costs everything. That's the rule tying the whole falls cluster together. Assess before you move. Question 30. A nurse is comparing 4 patients to identify the one whose risk for fall has just risen sharply within the last hour despite a normal admission screen. The nurse considers new medications, mental status changes, mobility shifts, and orthostatic findings during the evening assessment. Your options are A patient asleep with steady baseline vitals. B. Patient using cane and ambulating safely. C. Patient newly orthostatic after first diuretic dose. D. Patient eating supper with family present. Which would you go with? Lock it in before the reveal. The correct answer is C. Patient newly orthostatic after first diuretic dose. C is correct because new orthostatic findings after a first diuretic dose mean the patient may collapse on standing. The risk is now imminent and severe, so targeted fall prevention must be added beyond the original baseline screen. A is wrong because a sleeping patient with steady baseline vitals has not shifted toward higher risk. The nurse continues universal precautions, but no acute change has occurred that would alter the prevention plan in the moment. B is wrong because cane used with safe ambulation reflects steady function and a stable risk profile. The patient already had any needed targeted plan during admission, and no new cue today signals a sudden increase in risk. D is wrong because eating supper with family present provides supervision and is not a high-risk activity. The shared meal context lowers risk and does not introduce sedation, weakness, or fluid shifts that would change the plan. An admission fall risk score is only a snapshot taken at one moment under one set of conditions. Risk does not hold still, and a patient who screened low on arrival can become high risk within the hour. Several things can push risk upward mid-stay: a new medication, new confusion or a mental status change, a sudden loss of strength, or new dizziness with orthostatic findings on standing. Each can appear after the admission screen is filed, turning a steady patient into a vulnerable one. Orthostatic hypotension is the classic trigger. Normally, standing makes vessels tighten and the heart speed up to keep blood flowing to the brain. But when that adjustment fails, systolic pressure drops 20 points or more, or diastolic drops 10, and the patient can become lightheaded and collapse. A first dose of a diuretic is a common trigger, since pulling fluid volume from the body leaves less reserve to keep pressure up on standing. A patient who was steady before the dose may become newly orthostatic and dizzy afterward, a change the admission screen never saw coming. Words like new, first dose, and within the last hour flag rising risk, while baseline, stable, and unchanged mean nothing has moved. Static stratification counts what a patient walked in with, but dynamic risk watches for what changes during the stay. Question 31. A nurse caring for a confused, agitated patient who has been pulling at intravenous lines considers safe responses. Restraints are not the first step. The nurse selects the least restrictive intervention that may calm the agitation and protect the device while keeping the patient as free as possible. Your options are A. Reorient placements, remain at bedside. B. Apply 4-point bilateral wrist restraints. C. Sedate heavily with a benzodiazepine now. D. Place vest restraint over the chest. Don't overthink it. Which one feels right? The correct answer is A. Reorient. Placements remain at bedside. A is correct because reorienting, applying softer mitts to protect the line, and staying at the bedside are least restrictive measures. They maintain freedom while preserving safety and addressing the underlying agitation through human contact. B is wrong because 4-point wrist restraints jump straight to the most restrictive measure without trying gentler approaches. Such an escalation requires failed alternatives and an order, and it often worsens delirium and agitation. C is wrong because heavy benzodiazepine sedation can paradoxically increase confusion in older adults and depresses respiratory drive. Chemical restraint is not a first-line response and brings additional dangers to a fragile patient population. D is wrong because a vest restraint over the chest can compress breathing and cause asphyxia, especially in confused patients. The intervention is also more restrictive than necessary when softer alternatives have not been tried first. A restraint is anything that limits a person's freedom to move or to reach part of their own body, and it comes in two forms: physical, like a wrist strap or a vest, and chemical, a medication given to subdue behavior rather than treat a diagnosis. Both take away movement, so both fall under the same rules. The principle of least restrictive care organizes every safety response as a ladder. Nurses start at the bottom rung with the gentlest measure that could plausibly work, reorienting the patient and hunting for a treatable cause of agitation, and climb only when that has failed. Restraint sits at the very top, where the reasoning ends, not where it starts. Consider a confused older man who keeps tugging at his IV line. The least restrictive response reorients him with a calm voice, slips soft mitts over his hand so he cannot grip the side, and keeps a staff member close by, protecting the device while leaving his arms free. The trap exam writer's set is the reflex to reach for a device that sounds safe. 4-point wrist restraints, a chest vest, or a syringe of a benzodiazepine all promise fast control, but all three skip the ladder entirely. And heavy sedation is itself a chemical restraint that can deepen confusion and blind breathing in older adults. Watch for a confused, agitated patient pulling at a line, paired with a question about the first or best nursing action. That combination signals least restrictive reasoning. The idea underneath every related topic is simple. Freedom is the default, and restraint is only ever the last resort. Question 32. A nurse caring for a patient in soft wrist restraints reviews the monitoring schedule. The patient was placed in restraints 2 hours ago after multiple failed alternatives. The nurse identifies the most important action that should be repeated regularly while the restraints remain in use during this shift. Your options are: A. Remove restraints only at end of day. B. Tighten restraints to reduce wiggling. C. Document once per shift and continue. D. Check skin and circulation, release periodically. Got a guess? Lock it in. The correct answer is D. Check skin and circulation, release periodically. D is correct because frequent assessment of skin integrity, circulation, range of motion, and toileting plus periodic release prevents pressure, injury, and contracture. Ongoing safety review also confirms whether restraints can finally be discontinued. A is wrong because removing restraints only at end of day misses the periodic release schedule that protects skin and joints. Long uninterrupted application risks pressure, injury, contracture, and loss of dignity for the patient. B is wrong because tightening restraints to reduce wiggling raises injury risk by impairing circulation and skin integrity. Restraint snugness should always allow 2-finger clearance and never compromise blood flow or comfort underneath. C is wrong because documenting once per shift fails the standard for restrained patients, who need frequent reassessment. Skin checks, neurovascular checks, and toileting offers happen on a much shorter, regular interval per policy. Once a restraint is on, the nurse's job changes from deciding to watching. The patient can no longer shift a pinched wrist, relieve a sore heel, or even report a strap grown too tight. So the nurse must protect the body on the patient's behalf. The monitoring has several fixed parts. Nurses check the skin under each strap for redness or breaks, assess circulation through warmth and nail bed color, move the joints through their range so they don't stiffen, and offer toileting, fluids, and emotional support. Snugness has a clear rule separating safe from dangerous. A properly applied restraint allows about 2 fingers to slide between strap and skin. That small gap preserves blood flow, while a tighter strap can cut circulation, break skin, and compress nerves near the wrist. Timing is where students slip up most. Skin, circulation, and range of motion checks happen on a short repeating interval set by policy, often every 15 minutes to an hour, with periodic release built in so the limb can move and rest before the strap returns. Every reassessment is also a chance to remove the restraint the moment the danger has passed. Keep the cluster sorted. Alternatives come before restraint. But monitoring protects the body minute by minute once the straps are on. Question 33. A nurse is caring for a patient who tries to climb out of bed at night. The patient has confusion and an unsteady gait. The nurse looks for an alternative to restraints that is least restrictive, while still keeping the patient safe through the rest of the night shift. Your options are: A. Apply a vest restraint immediately. B. Lock all bed wheels and walk away. C. Bed alarm, low bed and frequent rounding. D. Sedate heavily with intramuscular medication. Which one is it? Pause the video if you need more time. The correct answer is C. Bed alarm, low bed and frequent rounding. C is correct because our bed alarm, low bed and frequent rounding form a layered alternative that protects the patient without restraint. Each component reduces risk through warning, lower fall height, and timely staff response throughout the shift. A is wrong because applying a vest restraint immediately skips less restrictive alternatives and requires an order plus failed attempts. The nurse must try gentler measures first and document their lack of success. B is wrong because locking the bed wheels and walking away leaves the patient at the same level of risk. The nurse must remain attentive and use cueing or alarms. Abandonment is unsafe and ethically wrong. D is wrong because heavy intramuscular sedation as a first response is chemical restraint and inappropriate without orders or attempts at alternatives. Sedation also depresses breathing and can worsen confusion, especially in older adult patients. Before restraint ever enters the picture, nurses have a toolkit of layered safety measures for a confused, unsteady patient. No single layer is perfect, so their real strength comes from stacking them together. A bed alarm warns staff the moment a patient starts to rise. A low bed and padded mat shrink the danger of a fall itself. And frequent rounding, the strongest layer, meets needs like toileting and pain relief before the urge to climb even begins. Picture the whole setup at once: an alarm sensor beneath the patient, the bed lowered close to the floor, a padded mat waiting below, and a nurse scheduled to check in every hour. Together, these tools watch the patient when no single one could. Reaching straight for a vest restraint skips the required alternatives and needs an order that isn't there yet. A sedative injection is chemical restraint with its own dangers, like slowed breathing. And simply locking the wheels and leaving does nothing but remove the person watching. Remember, safety isn't something you leave in the room, it's someone staying present. Stack the alarm, the low bed, the mat and the rounding, and the patient stays free and safe. Question 34. A nurse considers the rules around medical restraint orders for a violent, confused patient who has just hit a staff member. The nurse knows the order has specific requirements regarding renewal, indication, and the alternatives attempted before placement of the restraint device on the patient. Your options are: A. Order requires specific clinical reason and renewal. B. Order is open-ended once initially placed. C. Any nurse or aide may order. D. Restraint can stay on indefinitely without checks. Take a second. Which answer would you pick? The correct answer is A. Order requires specific clinical reason and renewal. A is correct because restraint orders must include a specific clinical reason, type, and time limit, and they must be renewed per policy. The structure protects the patient from indefinite or undocumented use of the device. B is wrong because open-ended restraint orders are not allowed under regulatory standards. Orders carry time limits and required reassessment intervals so that restraint use is reviewed and not continued without documented clinical need. C is wrong because only authorized providers can order restraints. Nurses and assistive personnel cannot write the order. The nurse may apply a restraint in an immediate emergency but must obtain a provider order promptly. D is wrong because restraints may not stay on indefinitely without regular checks and renewal. Skin, circulation, range of motion, and toileting must be assessed often, and discontinuation is sought as soon as safely possible. A restraint carries legal weight, so only a licensed provider can order one. A nurse may apply a restraint in a genuine emergency, but must promptly obtain that order rather than waiting for it first. 3 elements must appear in every valid order: a specific clinical reason, like pulling at a life-saving airway, the type of restraint permitted, and a firm time limit. Standing or as needed restraint orders are prohibited outright. The time limit connects to renewal. Orders for violent or self-destructive behavior are renewed roughly every 4 hours, with a hard 24-hour ceiling before a fresh in-person evaluation. Non-violent medical restraints like protecting a drain follow a longer daily cycle, but always with in-person reassessment. For the most restrictive situations, there's an added safeguard. When restraint or seclusion is used for violent behavior, a provider or specially trained practitioner must perform a face-to-face evaluation within 1 hour of application. That early in-person look guards against a restraint being started in crisis and simply left running. The key nuance is applying versus ordering. A nurse's hands may place the restraint, but a provider's order authorizes it, and that order can never be permanent, generic, or reused without renewal. Question 35. A nurse is caring for an older adult with delirium who has been pulling at the urinary catheter. The nurse considers the most important risk associated with restraint use in this population before any application, recognizing that the patient is especially vulnerable to specific complications during restraint. Your options are: A. Patient becomes more cooperative with restraints. B. Restraints can worsen delirium and entrapment risk. C. Restraints have no effect on cognition. D. Restraints always shorten the hospital stay. Before I reveal it, which one do you think is right? The correct answer is B. Restraints can worsen delirium and entrapment risk. B is correct because restraints frequently worsen delirium in older adults and carry serious entrapment and asphyxia risks. The nurse must weigh those harms against the perceived benefit and use less restrictive alternatives whenever possible. A is wrong because restraints rarely produce cooperation and often increase agitation as the patient struggles. The expected outcome is more distress, not less, which is one reason alternatives are tried first in this population. C is wrong because restraints have a substantial effect on cognition by increasing confusion, fear, and agitation. The claim that they have no effect ignores a large body of evidence on delirium worsening with restraint use. D is wrong because restraints have not been shown to shorten hospital stay. They often lengthen it through complications. Pressure injury, deconditioning, and prolonged delirium all extend the time needed for safe discharge home. Restraint looks like a neutral safety tool, something that simply holds a patient still until danger passes. But in a frail older adult, restraint creates new dangers of its own, and those dangers can be worse than the problem it was meant to solve. The harms fall into 4 categories. Restraint worsens delirium instead of calming it. Straps and vests create entrapment and asphyxia risk. Immobilized limbs stiffen toward contracture and skin breaks down. And clots, pneumonia, and prolonged delirium all combine to lengthen the hospital stay rather than shorten it. This is why entrapment is so dangerous. A confused patient sliding against a vest or working a limb between the mattress and the rail can end up with pressure across the neck or chest that stops breathing. It happens fastest in exactly the patient's restraints are used on. Think of it this way: a confused older adult who wakes to find their arms pinned does not feel protected, they feel trapped. That fear drives more struggling and deeper disorientation, amplifying the very confusion the restraint was supposed to fix. Restraint does not make patients calmer, does not leave cognition untouched, and does not shorten a hospital stay. These hazards are exactly why least restrictive care, alternatives, and monitoring all exist in the first place. Question 36. A nurse is feeding a patient who has had a stroke and recently been cleared for a soft diet. The nurse is reviewing positioning to prevent aspiration during meals. The patient sits in the chair beside the bed with the meal tray within easy reach during the lunch period. Your options are A. Position flat on back during meal. B. Tilt head back while patient swallows. C. Recline at 30 degrees during eating. D. Sit upright at 90 degrees during meal. What's your answer? Commit to one before I continue. The correct answer is D. Sit upright at 90 degrees during meal. D is correct because sitting fully upright at 90 degrees during and after meals reduces aspiration risk after stroke. Gravity helps direct food past the trachea, and the upright posture supports safe swallowing throughout the entire meal. A is wrong because lying flat allows food and gastric contents to enter the airway and is the worst position for aspiration risk. The patient cannot generate the swallow mechanics needed to keep the airway protected. B is wrong because tilting the head back during swallowing opens the airway to food rather than directing it to the esophagus. Chin tuck or neutral head position is generally preferred to protect the airway. C is wrong because reclining at 30 degrees is not adequate for active eating. The patient needs full upright posture for the swallow mechanics to work safely. Semi-recumbent angles increase the chance of aspiration. Aspiration happens when food, liquid, or saliva slips into the airway instead of the esophagus, because the epiglottis fails to seal the windpipe at the right moment. This can trigger choking, lung injury, or pneumonia days later. Body positioning is one of the strongest defenses we have. In a healthy swallow, the epiglottis folds over the trachea at just the right instant, sealing the airway while the bolus moves down the esophagus. When that timing fails, material heads toward the lungs instead. The core rule is simple. Sit fully upright at about 90 degrees and remain upright for a while after eating. Gravity then helps carry food down and away from the airway. The chin should stay neutral or tucked, never tilted back, since tipping it back opens a straight path into the trachea. Dysphagia after a stroke creates a gap between hunger and safety, which is why exam questions test position carefully. Lying flat is the most dangerous choice, and a partial recline of 30 degrees still isn't enough for eating. Remember that 90 degrees upright serves swallowing, 30 degrees head of bed serves pressure control, and left side lying serves an enema. Each answers a different problem. When a question pairs a meal with a swallowing problem, think airway protection, fully upright, chin tucked, and no half measures. Question 37. A nurse caring for a patient with a recent traumatic head injury considers positioning to support venous drainage from the brain and limit increases in intracranial pressure. The patient is on continuous monitoring and is otherwise hemodynamically stable for the entire current shift right now. Your options are A. Strict flat supine with neck flexed. B. Head turned sharply to the side. C. Head of bed at 30 degrees neutral. D. Trendelenburg position with feet elevated. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Head of bed at 30 degrees neutral. C is correct because A. Head of bed elevation around 30 degrees with the neck in neutral alignment helps venous drainage from the brain. The position reduces intracranial pressure without compromising cerebral perfusion in a stable patient. A is wrong because strict flat supine with the neck flexed obstructs venous drainage and can raise intracranial pressure. Flexion or extension of the neck both compromise jugular outflow and worsen pressure inside the skull. B is wrong because sharp head turning compresses jugular veins, restricts venous drainage, and raises intracranial pressure. Neutral head and neck alignment is preferred so that drainage from the cranium is not impeded by the neck position. D is wrong because Trendelenburg with feet elevated raises intracranial pressure by increasing venous return to the head. The position is harmful in head injury and should not be used unless reversing severe hypovolemic shock briefly. The skull is a rigid box holding brain tissue, blood, and cerebrospinal fluid, so anything that adds volume, like swelling or bleeding, raises intracranial pressure. Too much pressure squeezes the brain's blood supply, and positioning is one tool nurses use to keep it in check. Blood drains from the brain mainly through the jugular veins, which have no valves and rely on gravity and staying open. A sharp turn, a flexed chin, or even a snug collar can kink these veins the way a bent garden hose stops water, backing pressure up inside the skull. The goal is to help blood drain out without cutting off fresh supply coming in. Raising the head of the bed to about 30 degrees uses gravity to encourage venous outflow, while keeping the neck neutral, facing forward avoids kinking the veins. Lying flat removes gravity's help, and adding a flexed neck throttles drainage further. Trendelenburg, with feet raised above the head, is worse because it drives blood toward the brain. And 90 degrees bolt upright is a swallowing safety position, not one meant to lower brain pressure. Whenever a question mentions a head or brain injury, intracranial pressure, or promoting venous drainage, picture 30 degrees of elevation with a neutral neck, quietly keeping pressure from creeping upward. Question 38. A nurse caring for a bed-bound patient with a Braden score of 14 reviews the positioning schedule for pressure injury prevention. The patient is too weak to move independently, has continent toileting, and tolerates side-lying well. The nurse applies the standard repositioning interval used in clinical practice. Your options are: A. Reposition every 2 hours and document. B. Reposition every 12 hours each shift. C. Reposition only when patient complains. D. Reposition once during the entire night. Which would you go with? Lock it in before the reveal. The correct answer is A. Reposition every 2 hours and document. A is correct because repositioning at least every 2 hours redistributes weight off bony prominences and prevents tissue ischemia. The standard interval, paired with skin checks and pressure redistribution surfaces, is the cornerstone of pressure injury prevention. B is wrong because 12-hour repositioning intervals leave skin under prolonged pressure and risk tissue breakdown. The cycle of ischemia and reperfusion that leads to pressure injury can begin within hours, so longer intervals are unsafe. C is wrong because waiting until the patient complains misses the early phase of pressure injury, which can be silent. Many patients cannot voice discomfort, so the nurse must turn proactively rather than reactively in this situation. D is wrong because a single repositioning during a long night shift cannot prevent pressure injury in a bedbound patient. The risk grows quickly with prolonged pressure, especially over the sacrum, heels, and trochanters in immobile patients. Let's look at why sustained pressure damages skin and how nurses prevent it before it starts. Damage starts deepest over bony points where skin has little cushion beneath it, like the sacrum, heels, hips, and back of the head. Sustained pressure squeezes shut the tiny vessels feeding that skin, and starved cells begin to die. Nurses measure risk with the Braden scale, which rates areas like how well a patient senses discomfort, how moist the skin stays, how much they move, and how much friction and shear they endure. Scores add up, and a lower total means higher risk, calling for a more aggressive prevention plan. Turning every 2 hours is the floor, since the damaging cycle of squeezed and returning blood flow can start within a couple of hours. but turning is paired with other measures: a pressure redistributing surface, heels floated off the bed, and skin inspected at every turn, alongside managing moisture and supporting nutrition. Waiting for a patient to complain fails, because early damage is often silent and many at-risk patients can't report discomfort. The signal is an immobile patient and a schedule that beats the clock, not a symptom that arrives too late. Question 39. A nurse is preparing a patient for an enema. The nurse considers which position best supports administration and patient comfort by allowing easy passage of the tubing and gravity-assisted flow into the colon. The patient is alert, cooperative, and able to lie on either side throughout. Your options are A. Supine with knees together, B. Prone with arms above the head, C. Half Fowler at 90 degrees, D. Left lateral with right knee flexed. Don't overthink it. Which one feels right? The correct answer is D. Left lateral with right knee flexed. D is correct because the left lateral or modified Sims position with the right knee flexed follows the natural curve of the sigmoid colon. The arrangement eases tubing insertion and lets gravity assist solution flow into the rectum. A is wrong because supine with knees together does not align with the sigmoid curve and makes insertion uncomfortable. The position also reduces gravity assistance and increases the risk of rectal trauma during the procedure. B is wrong because prone with arms overhead is uncomfortable and impractical for enema administration. The nurse cannot easily access the rectum or monitor the patient's comfort and reaction during the procedure in this posture. C is wrong because half Fowler at 90 degrees works against gravity for fluid retention and is not the standard for enema administration. The patient may also have difficulty holding the solution upright for the necessary minutes. Positioning for an enema isn't arbitrary comfort, it's pure anatomy. The lower colon curves toward the left side of the body, and good positioning means working with that curve instead of against it. After the rectum, the colon doesn't run straight. It curves as the sigmoid colon toward the left, then joins the descending colon running up the left side of the body. That leftward bend is the whole reason position matters. The correct position is left lateral, refined to Sims, lying on the left side with the right knee drawn toward the chest. Lying left lines up gravity with the colon's natural downhill path, while the flexed knee opens the area for easy, visible tubing insertion. Other positions fight this anatomy. Lying supine gives no gravity-assisted awkward access. Prone leaves the nurse unable to watch the patient, and sitting upright lets gravity pull the solution right back out before it can work. Whenever a procedure sends fluid into the rectum and colon, remember the sigmoid's leftward curve. Left lateral Sims lets gravity and anatomy work together for a gentler, safer enema. Question 40. A nurse cares for a patient one day after a total hip arthroplasty using the posterior surgical approach. The patient is alert, comfortable, and able to follow directions. The nurse must select the safest positioning instructions to prevent dislocation of the prosthesis during the early post-operative recovery period. Your options are A. Cross legs at the ankle and knee, B. Bend hip past 90 degrees freely, C. Keep abductor pillow between legs and bed, D. Rotate operative leg internally for comfort. Got a guess? Lock it in. The correct answer is C. Keep abductor pillow between legs and bed. C is correct because an abductor pillow between the legs maintains hip abduction and prevents dislocation of the new prosthesis. Posterior approach precautions also include avoiding extreme hip flexion, internal rotation, and crossing legs at any point. A is wrong because crossing the legs at the ankle or knee places the operative hip in adduction and increases dislocation risk. The patient must keep the legs apart and avoid the cross position during the early healing weeks. B is wrong because flexing the hip past 90 degrees can dislocate the prosthesis after a posterior approach. Patients must keep hips at less than 90 degrees during sitting, transfers, and toileting to protect the joint. D is wrong because internal rotation of the operative leg places dangerous strain on the new joint and risks posterior dislocation. The leg should remain in neutral or slight external rotation to keep the prosthesis stable. After a posterior hip replacement, the back of the joint is unstable for weeks while tissue heals. Certain movements can pop the new ball out of its socket, causing a painful dislocation. Positioning precautions exist purely to keep that joint seated until it stabilizes. 3 movements are banned after a posterior approach: bending the hip past 90 degrees, crossing the operative leg over the midline, and rotating the leg inward. Each one levers the back of the joint open, letting the ball slip backward out of the cup. The abductor pillow is the single most useful tool, a wedge strapped between the legs in bed. It holds the legs apart in abduction, the safe opposite of crossing, and blocks the operative leg from rolling inward while the patient sleeps. The same abduction principle applies everywhere, not just in bed. Chairs and toilet seats are raised so hips stay above the knees. Feet point forward instead of turning in, and reaching down for socks or shoes is avoided because it forces deep hip flexion. Whether it's crossing at the ankle, bending to grab a dropped item, or letting the toes roll in, each disguised motion still risks dislocation. The rule is simple: keep the new joint abducted and out of deep flexion so the ball stays in the socket. Question 41. A nurse on a busy unit smells smoke and sees flames coming from a wastebasket in a patient's room. The nurse remembers the RACE acronym used in fire response and considers the first step that should be taken immediately to protect the patient before any other action. Your options are: A. Rescue the patient from danger first. B. Sound alarm before moving the patient. C. Try to extinguish the fire with water. D. Close the door and walk away. Which one is it? Pause the video if you need more time. The correct answer is A. Rescue the patient from danger first. A is correct because the first step in RACE is rescue, which means moving the patient out of immediate danger. Removing the patient from the room comes before the alarm, containment, and any extinguisher used during a fire. B is wrong because sounding the alarm is the second step in RACE and follows rescue. Pulling the alarm before moving the patient leaves the most vulnerable person closest to the fire, while precious seconds are spent on signaling. C is wrong because attempting to extinguish a fire is the last step in RACE and should never come before rescue. Water also is not safe on every fire type, so extinguisher selection matters too. D is wrong because closing the door without rescuing the patient first leaves the patient alone in danger. Containment matters, but only after the patient has been moved and the alarm activated to bring help. In a healthcare setting, patients can't simply run from a fire. That's why every staff member learns a fixed sequence for fire emergencies, remembered by the word RACE. RACE stands for Rescue, Alarm, Confine, and Extinguish. The order matters as much as the actions themselves, because doing the right thing at the wrong time can cost a life. Rescue comes first because the patient nearest the fire has the least time to escape. Most fire deaths come from smoke inhalation, not flames, and a room can fill with toxic smoke in under 2 minutes. So pulling the alarm or grabbing an extinguisher before moving that person costs precious seconds. Picture a nurse finding a wastebasket fire near a stroke patient who cannot move. She moves the patient out first, pulls the alarm in the hallway, closes the door to hold back the smoke, and only then considers the extinguisher if the flames are still small. Whenever an exam question places a patient in a room with fire, rescue comes first. And remember, RACE governs the whole event, while PASS only describes how to operate the extinguisher once the patient is already safe. Question 42. A nurse confronts a small contained fire in a metal trash can and reaches for a fire extinguisher. The nurse remembers the PASS acronym for using the extinguisher correctly. The nurse must select the action represented by the first letter of the PASS acronym before discharging the device. Your options are A. Aim nozzle at top of flames. B. Pull the safety pin from the handle. C. Squeeze the handle smoothly to release. D. Sweep across the fire from the top. Take a second. Which answer would you pick? The correct answer is B. Pull the safety pin from the handle. B is correct because the first action in PASS is to pull the safety pin so the extinguisher can be discharged. Without pulling the pin, the device cannot release the extinguishing agent regardless of how the handle is squeezed. It is wrong because aiming the nozzle at the top of flames is wrong even after pulling the pin. The agent should be aimed at the base of the fire where the fuel is rather than at the visible flames. C is wrong because squeezing the handle is the third step and cannot work unless the pin has already been pulled. Without the prior pull, the safety lock prevents the agent from coming out at all. D is wrong because sweeping is the fourth step and should be applied side to side at the base of the fire. Sweeping from the top misses the fuel and wastes the limited extinguisher charge during the fire response. A fire extinguisher only holds 8 to 20 seconds of charge, so there's no room to fumble. PASS compresses the correct technique into 4 fixed motions: pull, aim, squeeze, and sweep. Pull removes the safety pin that locks the handle, since squeezing does nothing while it's still in place. Aim targets the base of the fire, not the flames, because that's where the fuel is actually burning. Squeeze releases the agent slowly and evenly to avoid wasting the limited charge. Sweep moves the nozzle across the full width of the fire until it's out. The flames themselves are just burning gas rising off the surface. The actual fuel sits at the base. That's why aiming low at the seat of the fire is the detail tested again and again. PASS should never be confused with RACE, which governs the entire emergency response and places extinguishing last, only after patients are rescued and the alarm is sounded. PASS is simply the hands-on technique used once you've already reached that final step. With patients clear and the alarm already sounded, the nurse pulls the pin, aims at the base, squeezes in one steady motion, and sweeps until the fire is out. Question 43. A nurse is teaching a patient newly discharged on home oxygen therapy about safety in the household. The patient cooks daily, has a gas stove, and lives with 2 adult relatives who smoke. The nurse provides specific guidance to reduce the risk of fire and serious injury while using oxygen. Your options are A. Keep oxygen tubing near the gas burner. B. Smoke in the same room briefly only. C. Store extra tanks in direct sunlight always. D. Avoid open flames and smoking near oxygen. Before I reveal it, which one do you think is right? The correct answer is D. Avoid open flames and smoking near oxygen. D is correct because oxygen supports combustion, so any open flame or burning cigarette creates a serious fire risk. Patients must keep oxygen far from gas burners, lighters, candles, and smokers, and post no smoking signs in the home. A is wrong because keeping oxygen tubing near a gas burner places a flammable concentration of oxygen against an ignition source. The combination has caused severe burns and house fires in patients on home oxygen therapy. B is wrong because smoking briefly in the same room is still dangerous, because oxygen lingers in clothing and surfaces. Even without an active flame in hand, residual heat and embers can ignite the oxygen-rich environment. C is wrong because direct sunlight raises tank temperature and pressure, increasing the risk of failure or rupture. Tanks should be stored upright in cool, well-ventilated spaces away from heat sources, sunlight, and ignition. Home oxygen therapy keeps people with chronic lung disease breathing well outside the hospital, but it brings one serious danger every family must understand. Oxygen itself does not burn, but it makes everything around it burn faster and hotter. Fire needs three things: fuel, heat, and oxygen. Room air is only about 21% oxygen, but a home oxygen setup floods the air around the patient's face, clothing, and bedding with a much richer concentration, so a spark that would normally die instead becomes a flame. Open flames and burning cigarettes are the first hazard to eliminate, since no one should smoke where oxygen is in use. An oxygen residue can saturate hair and clothing fibers. Keep equipment at least 5 feet from any open flame or heat source, and about 10 feet from a gas stove. Tanks should stand upright and secured so they cannot fall and shear off the valve, kept in a cool, well-ventilated space. Heat raises internal pressure toward failure, so sunlight, hot car trunks, and areas near furnaces are poor storage choices. Whenever you see home oxygen paired with smoking, cooking, candles, or storage, the safe answer always moves ignition sources away from the oxygen. This is fire prevention, not fire response, so it stands alongside race and pass rather than replacing them. Question 44. A nurse during a true fire on the unit must decide which patient to evacuate first when help is limited. The nurse remembers the order based on patient ability to move and proximity to danger. Several patients have differing levels of mobility and current locations during the fire response. Your options are: A. Begin with the most distant patient. B. Evacuate sleeping patients only at end. C. Move ambulatory patients nearest fire first. D. Take comatose patient immediately first. What's your answer? Commit to one before I continue. The correct answer is C. Move ambulatory patients nearest fire first. C is correct because ambulatory patients close to the fire move quickly with minimal help and clear the corridor for others. After ambulatory rescue, the nurse moves wheelchair patients and finally bedbound patients with greater equipment and personnel needs. A is wrong because starting with the most distant patient delays rescue of those nearest to the active danger. The closest at-risk patients face the most heat and smoke and must be moved out of the immediate fire zone first. B is wrong because evacuating sleeping patients at the very end ignores their actual location and ability. A sleeping patient near the fire must be rescued early. The nurse evacuates by location and mobility, not sleep state alone. D is wrong because taking the comatose patient first uses up early staff time on the slowest, heaviest move. Ambulatory patients can self-rescue with minimal direction. Bedbound and unconscious patients are evacuated last when more help has arrived. When a fire forces a real evacuation with only a few staff on hand, someone has to decide who leaves first. That order isn't random, so it's built on two factors: mobility and proximity to danger. The governing rule is that ambulatory patients closest to the fire go first, since they only need direction and can walk themselves out in seconds. Spending precious minutes carrying one bed-bound patient ties up several staff while walking. Patients wait in a smoke-filling hallway. So moving the quick cases first rescues the most people fastest. After the ambulatory patients are out, the order steps down by mobility, wheelchair patients next, then bed-bound patients, and fully dependent or unconscious patients last. Saving the slowest, most resource-heavy rescues for last is deliberate. Time for when more help has arrived. There's also a larger pattern layered on top. Evacuation moves horizontally first, shifting patients sideways through fire doors into an adjacent safe compartment on the same floor before anyone goes down a stairwell. Fire doors are engineered to hold back smoke just long enough to make that lateral move work. This ordering is distinct from everyday triage by acuity, where the sickest patient is seen first. In a fire, speed of rescue and closeness to danger set the sequence. So the correct answer names the ambulatory patient nearest the flames. Question 45. A nurse witnesses a small fire in a humidifier plugged into the wall outlet of a patient's room. The nurse considers which type of fire extinguisher to use, given that electricity is involved. The nurse selects the safest extinguisher class for an electrical fire while keeping bystanders out of harm. Your options are A. Class C extinguisher rated for electrical fires. B. Bucket of water from the patient bathroom. C. Wet towel placed directly on outlet. D. Class A extinguisher for ordinary trash. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Class C extinguisher rated for electrical fires. A is correct because Class C extinguishers are rated for electrical fires and use non-conductive agents that do not transmit current. The nurse selects the labeled Class C device or a multi-purpose ABC extinguisher to put out the fire safely. B is wrong because water conducts electricity and can shock the user when applied to a live electrical fire. Pouring water on a powered device may also spread the fire and is never the safe choice for energized equipment. C is wrong because a wet towel applied directly to a powered outlet creates an electrical hazard for the nurse. The wet material conducts current and risks burns and electrocution rather than a safe, contained extinguishing action. D is wrong because a Class A extinguisher is rated for ordinary combustibles like wood, paper, and cloth, but not for electrical fires. Using Class A on an electrical fire risks shock and ineffective extinguishment of the source. Not every fire burns the same fuel, so not every fire is put out the same way. Grabbing the wrong extinguisher can spread the flames, cause an explosion, or electrocute the person holding it. That's why fires are sorted into classes, and extinguishers are rated for the classes they can safely handle. Class A covers wood, paper, and cloth put out with water or a standard extinguisher. Class B covers flammable liquids like gasoline and oil, where water only spreads the flame. Class D handles burning metals, and Class K covers kitchen grease fires. Because carrying 5 extinguishers is impractical, many facilities mount a multi-purpose ABC unit as a reliable default. Class C, the one exam writers love, covers energized wiring, motors, and plugged-in equipment. Its defining feature is a non-conductive agent, like carbon dioxide or dry chemical, that smothers the fire without carrying current back to the person spraying it. Water conducts electricity, so pouring it or laying a wet towel on a live outlet sends current straight to your hands. Picture a nurse finding a small fire from a humidifier plugged into the wall. Electricity is involved, so the safe choice is a Class C or ABC extinguisher aimed at the base of the fire, never water from the sink, which would turn a contained fire into a shock hazard. On exam day, watch for words like electrical, plugged in, or outlet paired with a choice of extinguisher. The safe pick is always Class C or ABs, while water or a wet cloth is the trap. Class ratings answer one question: which device is safe for what's actually burning? Question 46. A nurse is preparing to administer a scheduled antibiotic. The nurse must use the standard for patient identification before any medication, procedure, or specimen collection. The unit uses wristbands and the chart has been verified earlier this shift. The nurse selects the safest identification practice now. Your options are A. Match by room number alone. B. Confirm name with the roommate. C. Match face to chart photo only. D. Use 2 identifiers like name, birth date. Which would you go with? Lock it in before the reveal. The correct answer is D. Use 2 identifiers like name, birth date. D is correct because using 2 patient identifiers, such as full name and date of birth, is the universal safety standard. The practice catches mix-ups when patients have similar names, share rooms, or move between units during a shift. A is wrong because room number alone has caused many wrong patient errors when patients are moved or rooms reassigned. The room is not a reliable identifier and never substitutes for verifying personal information against the chart. B is wrong because asking a roommate to confirm name introduces error and breaches privacy. The patient or chart, not a neighbor, is the correct source for identifiers, and the roommate may not know the patient's true name. C is wrong because matching face to chart photo can fail when a photo is outdated or the patient looks different. A single source of identification is not enough. Two distinct identifiers are the standard for a reason. Before any medication, specimen, or procedure, one small step prevents enormous harm, confirming the right care goes to the right person. The national standard is checking two patient identifiers every single time. Valid identifiers travel with the patient no matter where they're placed. Full name and date of birth are the most common pair, but a medical record number, a photo, or a wristband barcode can also serve as one of the two. A room number or bed location describes a place, not a person, and patients get moved or swapped constantly. Asking a roommate to vouch breaches privacy and invites error, and matching a face to an old photo alone isn't enough either. The safest practice is active identification. The nurse asks the patient to state their own name and birth date, then matches that against the wristband and the medication label. This works in the reverse direction of simply asking a patient to agree with the name spoken aloud. Even a nurse who has cared for a patient all shift still checks name and date of birth against the wristband and the order. Familiarity is exactly how wrong patient errors slip through, so the check happens every single time. Question 47. A nurse receives a telephone order from the on-call provider for a new medication and dose. The unit policy requires a specific verification process to reduce errors caused by mishearing names, doses, or routes. The nurse considers the safest practice for the verbal exchange before charting and administering. Your options are hang up and chart the order quickly. B. Ask another nurse to repeat to provider. C. Read back order to provider verbatim. D. Sign the order without further verification. Don't overthink it. Which one feels right? The correct answer is C. Read back order to provider verbatim. C is correct because reading the order back to the provider verbatim allows correction of misheard medications, doses, or routes. The structured readback is a verbal version of independent verification and prevents many telephone order medication errors. A is wrong because hanging up and charting quickly skips the verification needed for verbal orders. Without readback, mishearing a sound-alike drug name or wrong dose can become a serious medication error before anyone catches it. B is wrong because asking another nurse to repeat the order to the provider does not include the receiving nurse who will carry it out. The nurse who heard the order must read it back personally to confirm understanding. D is wrong because signing the order without verification eliminates the safety check entirely. Verbal orders carry higher risk for sound-alike confusion, so additional verification through readback is required by most facility policies. Verbal and telephone orders are fast and convenient, but they exist only as sound for a moment, which makes them one of the easiest ways an error can enter a patient's care. There's no written source to double-check because the nurse is creating the record from what she heard. That single spoken exchange is the moment an error either gets caught or gets locked in. The process has a fixed shape. First, the nurse writes the order exactly as given, then reads it back word for word, including drug name, dose, route, frequency, and special instructions. And only after the provider confirms does the order become active. Reading back verbatim, not paraphrasing, is what catches the mistake. So the nurse repeats the actual drug name letter by letter and states the dose clearly. Ensuring 5 milligrams is never mistaken for 15. It must be the nurse who received the order doing the readback, not a clerk or a second nurse, because only that person can confirm what they actually heard. On exam day, when you see a telephone or verbal order, the safest next action is always read it back for confirmation. Question 48. A nurse calling a provider about a patient with worsening shortness of breath plans the message using a structured communication tool. The nurse wants to give a clear summary that will move the provider to a decision quickly. The nurse selects the framework most consistent with this safe handoff approach. Your options are A. Situation, background, assessment, recommendation framework. B. Long detailed history, first then situation. C. Random order of facts as they come. D. Diagnosis only with no other context. Got a guess, lock it in. The correct answer is A. Situation, background, assessment, recommendation framework. A is correct because situation, background, assessment, and recommendation create a structured handoff that delivers the most important information upfront. The framework helps providers act quickly because the request and reasoning are clearly stated. B is wrong because leading with a long detailed history before the situation buries the urgent point. Providers need the immediate concern first, with background and supporting data following so the call drives a decision. C is wrong because a random order of facts wastes the provider's time and obscures the clinical urgency. Structured communication exists to reduce this kind of confusion, especially during rapid changes in patient condition during care. D is wrong because sharing only the diagnosis without context, vital signs, or recommendation gives the provider too little to act on. The provider needs the situation, current findings, and a specific request from the nurse. SBAR is a structured way to organize a clinical conversation so the most urgent information comes first and moves the listener toward a decision. It began in high reliability settings like the military and aviation, where a garbled message can be fatal, and was adopted in healthcare because communication breakdowns are a leading cause of preventable harm. The problem SPAR solves is that people naturally ramble, building slowly toward the point. A provider woken at 3 in the morning needs the urgent fact immediately, not a chronological narrative. So a shared structure puts caller and listener on the same map. Situation opens the call, stating who the patient is and what's happening right now. Background gives the relevant context, diagnosis, history, medications, and recent changes. Assessment is the nurse's own judgment from current findings, not just raw numbers. Recommendation, the step most often dropped, states clearly what the nurse wants the provider to do. Picture a nurse whose heart failure patient is growing more short of breath. She opens with the situation, gives the background of the admission and fluid status, offers an assessment of rising respiration and falling saturation, and closes with a recommendation to evaluate now and consider a diuretic and chest film. On exam day, watch for a nurse calling or handing off to a provider about a changing patient and asking for a structured communication tool. SPOR is about how nurses talk to providers, distinct from patient identification and readback safeguards, which confirm the right patient rather than organizing the message itself. Question 49. A nurse preparing 2 medications notices that the names on the labels look similar and could be easily confused. The institution uses tall man lettering and has flagged the drugs as look-alike sound alike. The nurse considers the safest practice for handling these medications during the morning round. Your options are A. Pour both into the same cup quickly. B. Verify each label using tall man lettering. C. Skip the label since they look alike. D. Trust the order entry without checking. Which one is it? Pause the video if you need more time. The correct answer is B. Verify each label using tall man lettering. B is correct because verifying each label and using the tall man lettering helps the nurse distinguish between similar names. The visual cue draws attention to the differing letters and reduces wrong medication errors during preparation and administration. A is wrong because pouring two medications into the same cup quickly removes both the labeled identification and the chance to verify. Mixing lookalike drugs during preparation increases the chance of giving the wrong drug or wrong dose. C is wrong because skipping the labels removes the primary safety check and ignores the warning that the drugs are lookalike. The labels exist precisely to prevent the error that the nurse would otherwise be inviting through neglect. D is wrong because trusting order entry without checking the medication label fails the 3 checks process. Order entry errors do happen, so the nurse must verify the label against the order, the patient, and the indication. Some drug names look so similar on a label or sound so similar when spoken that they're easy to mix up. These are called look-alike. Sound-alike drugs or LASA, and confusing them is dangerous because the two drugs usually do completely different jobs. A busy nurse scanning shelves reads the shape of a word more than every letter, so two similar names blur together. Spoken orders make it worse, since names that sound alike over the phone are easily transposed. Tall man lettering is a key defense. It writes the differing part of a confusable name in capital letters while the shared part stays lowercase. This pulls the eye straight to the letters that actually distinguish the two drugs, breaking the automatic pattern matching that causes mix-ups. The label check lives inside a larger habit called the 3 checks. Verifying the medication against the order while pulling it, again while preparing it, and once more at the bedside. Screens alone aren't enough, since entry errors happen too, so the physical label must be matched against the order every time. One drug at a time, never pouring two lookalikes together. On exam day, watch for signal words like similar drug names, lookalike or sound alike, and tall man lettering. The safe practice is always the same. Verify each label individually using the tall man cue and the standard checks. Question 50. A nurse notices that a near miss occurred when a colleague nearly administered a wrong dose but caught the error before reaching the patient. The unit follows a just culture approach, and the nurse considers the most appropriate action that supports learning and prevents repeat errors across the team. Your options are A. Hide event to protect the colleague. B. Reprimand the colleague harshly in private. C. Ignore since no harm reached patient. D. Report the near miss for system review. Take a second. Which answer would you pick? The correct answer is D. Report the near miss for system review. D is correct because reporting near misses through the Just Culture system identifies process gaps that can be redesigned. The data drives system improvement, supports the colleague through learning, and protects future patients from the same potential error. A is wrong because hiding the near miss blocks system learning and leaves the underlying weakness unfixed. Just Culture replaces blame with reporting precisely, so honest disclosure can lead to better processes for every nurse on the unit. B is wrong because harsh reprimand discourages reporting and does not address the contributing system factors. Just Culture distinguishes between human error and reckless behavior, and most near misses arise from process problems rather than personal fault. C is wrong because ignoring the near miss because no harm occurred wastes valuable learning that could prevent harm next time. Near miss data is one of the most powerful sources of safety improvements available in healthcare today. Just Culture is a way of responding to mistakes that sits between two failed extremes, punishing every error, which teaches people to hide problems, and excusing everything, which lets real recklessness slide. Fear kills reporting, and unreported problems never get fixed. In a blame culture, a nurse who nearly errs stays quiet, so the real weak spot stays hidden, waiting to catch the next person. Because most errors come from badly designed systems, confusing labels, interruptions, understaffing, and unclear orders. Just Culture sorts behavior into 3 categories: Simple human error calls for consoling the person and fixing the system. At risk, behavior calls for coaching and removing the incentive to cut corners. And only reckless behavior, a conscious disregard of known serious risk, warrants accountability. A near miss is an error caught before it reaches the patient, like a nurse who pulls the wrong dose but catches it at the bedside check. No one is harmed, but the event is a gift, exposing a hole in the process without anyone paying the price. The right response to a near miss is to report it through the safety system for review, supporting the colleague rather than shaming them. On exam day, remember, just culture means reporting the event without blame, so the system gets fixed before harm ever occurs. That's a wrap on our practice question review of nursing process and safety. If you're looking for more practice, our website has hundreds of free questions plus complete study guides, all ready and waiting for you to use. Everything you need is right there, organized and easy to access. Just click the link in the description below to check it out and start practicing today. Be sure to subscribe for more reviews coming soon, and good luck on your HESI Fundamentals exam.